Good afternoon and welcome all to the third International Practical Pediatric Endocrine course. I'm really pleased to have faculty from across the country as well as from different parts of the world who will be joining in this two-day program. This is a unique program which provides us opportunity to interact on key aspects of pediatric endocrinology, ranging from growth, puberty, thyroid growth, and other disorders. So before we start the program, I'd like to have the feedback from many of the people who have been involved with us for quite some time. I have Dr. Vishnu, who is a professor at SMS Jaipur. Dr. Vishnu.
Sir, good afternoon to all of you. This is a wonderful program. Since it is not possible quite some time to conduct this program in physical way, so it is a very good way of conducting practical pediatric endocrinology course, and it gives us a detailed insight to everybody.
Thank you,
So
Dr. Vishnu,
I
and
would
all
like
the
to thank
people.
Dr. Anurag Vajpayee sir for conducting this program regularly. Thank you, sir.
Thank you, Dr. Vishnu, and all the people who are here. We have done PPC actually at ground as well with Dr. Arpita at KGMU, Dr. Manisha at Prayagraj. So, Dr. Arpita, we like to have your thoughts.
Yes, sir. So this is a very good program, and it gives an overview of the whole pediatric endocrinology over a period of 1 and 2 days. So it gives a very good experience for the postgraduates and the people who are interested in pediatric endocrinology to attend this course.
Thank you, Dr. Arpita. We've got Dr. Manisha from Prayagraj, Professor, Department of Pediatrics. Dr. Manisha.
Yes, sir. According about the course is very good. Initially, we start to just to learn few things about endocrinology, but since this course is so good, everyone starts loving endocrinology, pediatric endocrinology. Sir makes it so easy, so practical that we start loving and make it a passion. Thank you very much, sir, for doing it. Thank you, sir.
Thank you, Dr. Manisha. Dr. Vijay Jaiswal, Professor Pediatrics from Saharanpur Hospital. Yeah.
Yeah. Good afternoon, each and everyone. I really appreciate the way that Dr. Anurag sir is doing wonder in pediatric endocrinology. Initially, people were thinking that this is a type of complicated or mystery subject, but now it is demystified. And all praise to Dr. Anurag sir, particularly for making these easy things a difficult topic. So I really appreciate. Thank you, sir.
Thank you,
नमस्कार.
Dr. Vikas.
विजय भाई नमस्कार.
नमस्कार सर, नमस्कार.
Yeah, Dr.
आगे
Vikas,
स्मार्ट
your
है.
views.
हाँ. बेसिकली मेरा ये मानना है कि डॉक्टर वाजपेयी सर ने जो काम किया है कि नाउ पीडियाट्रिक एंडोक्राइनोलॉजी इज ए हाउस होल्ड तो नहीं कहूँगा, लेकिन लोगों को समझ में आने लगा कि ग्रोथ क्या है. एम आई ऑडिबल?
यस प्लीज गो अहेड.
तो बस समझ में लोगों को ये आ रहा है कि ग्रोथ क्या है, ग्रोथ हार्मोन क्या है. अदरवाइज तो पहले ग्रोथ हार्मोन नाम सुनते ही लोग परेशान हो जाया करते थे. इंजेक्शन टेस्टोस्टेरोन क्या है, डिजाइनर इंसुलिन क्या है, बेसल बोलस क्या है. At least when you talk about these topics, so people are able to understand it. So this is, I think, this is the biggest achievement of Medi classes and Dr. Vajpayee and the team's hard work. At least we are not able now. We don't have to convince our fellow practitioners that basal bolus is something. Otherwise, initially they used to say, "Why you are doing 4 sugars in a day?" So now the things are getting propagated, and in a larger interest of the children with pediatric endocrine disorder, this is a boon. Because in pediatric endocrinology, two things are very, very important: when to refer and how to refer, and to whom to refer. Because biological clock is not giving you time. This is very, very important, which is unique for this particular subject. Because biological clock has to be respected. And every grassroots level worker, because everybody cannot reach directly to pediatric endocrinologists. So now people are understanding that this child has got something different, and he or she might need some specialized opinion. And now we have got people to address that need also. Everybody don't have to rush to metros everywhere because of the expansion of medical classes. Somebody sitting in Kanpur, somebody in Fatehpur, somebody in Aligarh, somebody in Mathura, and Jaipur is a larger town. And I hope this keep on growing. So that the dream of Dr. Vajpayee, as we have discussed around in 2002, that he want to establish small clinics at every roots and corners of the country. Initially, it was sound to be very tough time, but now I think समय बहुत पास आ गया है कि हमारा ये सपना सच होने वाला है और यकीन मानिए, बिलीव मी, डॉक्टर वाजपेयी लोगों को आवश्यकता है।
Thanks, Dr.
And
Vikas, for the
बस
nice.
बस खत्म कर रहा हूँ, आखिरी सेंटेंस और मेरा, संवेदनशील हमें होना होगा और संवेदनशीलता के साथ में हो सकता है एक बच्चा जो जिसके फादर चाउमीन का ठेला लगाते हैं उसको भी बच्चे को डायबिटीज होती है, तो बीमारी देखती नहीं है कि रिसोर्सेज यहाँ नहीं है। तो वी नीड मोर पीपल ऑफ यू एंड योर टीम and believe me, I promise you that we are all together to spread the knowledge and the awareness to address the need of these children. Thank you very much.
Thank you. We have got Dr. Padma Priya from Trichy. Dr. Padma Priya.
Good afternoon, sir.
Namaskar, Dr. Palbiya. Namaskar.
Good afternoon, sir. Thank you for giving me this opportunity, sir. Actually, endocrinology is a very difficult subject as according to me before attending the MIDI class, but now it has become so easy. We are doing decent job even in our place. So it has turned our dimension seeing the endocrinology, sir, makes it so simple. I am very happy that people are going to learn in these 2 days shortly about how to deal. And as usually, sir used to tell, like, it is not worth to miss any case and not to evaluate any case unnecessarily. So this is going to be a great eye-opening for everyone if they are going to listen to the class for the next 2 days, sir. Thank you for giving the opportunity to everyone, sir. Thank you.
Thank you, Dr. Padma. Dr. Balaji is there from SRM. He's the head of pediatrics at SRM Chennai.
Good afternoon, sir. Good afternoon. And thank you for inviting me as a resource person. And it's a wonderful platform, sir. Medi Classes is a wonderful platform. You have been doing a wonderful job by teaching us, updating us in pediatric endocrinology, and especially for working faculties where we are unable to reach out to do the regular fellowships. So this is a wonderful use, and this course is fully case based, so that is the special part actually. So there will be no boring lectures. So every module has been done as a case based. So I think postgraduates and practicing pediatricians will enjoy it, and I urge everyone to build on this and do long-term courses with the Medi classes. Thank you, sir. Thank you.
Thank you, Dr. Balaji. We've got Dr. Jyoti Agarwal from Dharan, Nepal. Dr. Jyoti. Dr. Jyoti is not responding. Dr. Mahesh is from Nepani in Karnataka, and he's been very enthusiastic in pediatric endocrinology and all aspects of pediatrics. Your words, sir.
Yes, sir. Thanks for giving this opportunity, sir. I'm a general practitioner basically, but because of your MADI classes, we could diagnose 17 hydroxylase deficiency in OPD itself. That is a wonderful. That's a message I want to give, that a general pediatrician like me also can do a endocrinology better with your modules. So I have joined this module. I have a app, your app, and I urge every general practitioner to use this app in a different situations. Thank you.
Thank you, Dr. Mahesh. Dr. Rajiv Bansal is with us. He is from senior pediatrician from SDMH Jaipur.
Good evening. It's such a pleasure to be part of the panel today. I've been Dr. Bajpayee's admirer since quite a long time. And in fact, I did a certificate course under his guidance. And this made me, because I deal with thalassemia, it helped me a lot in managing endocrine problems of my thalassemics. In fact, we have got a DNB program and encouraged my students to be part and parcel of these MADI classes so that they can learn pediatric endocrinology in a very concise and a very systematic manner. Sir's all modules are excellent, and it's so easy for somebody to meticulously follow all the instructions which are given, and even the app which has been formed, that they can sail through the majority part of the pediatric endocrinology in their day-to-day practice. So I recommend each and everyone. In fact, all of my students are encouraged to enroll, or rather join even a 1 or a 3-year course with Dr. Bajpayi to learn pediatric endocrinology, which to my mind is the most important part of a day-to-day routine pediatric OPD or indoor practice. So all the good luck to the whole team. And thank you very much for encouraging all of us. Thank you.
Thank you, Dr. Bansal. We've got Dhwani, who has been our fellow and now working as a pediatric endocrinologist in Chapra, Bihar. Dhwani?
Hello, good afternoon, sir. I am extremely privileged to have trained under Anurag sir and Rishi sir, and I have now started my practice in Chapra, Bihar. To all the pediatricians and pediatric trainees who will be attending this course, let me tell you, it is a concise pathophysiology base, so you understand what is happening and why it is happening. And the case-based scenarios are those that you will encounter in your day-to-day practice. So that will, when you go through these cases, you will instantly feel like, oh, I have seen a similar case. And next time when you see those cases, you will know exactly how to approach them and how to go about how to manage them further. So it will be an excellent course for you guys.
Thanks, Vani. We have got Dr. Varsha from Sindh, Pakistan, Karachi. She's a pediatric endocrinologist. So, Dr. Varsha, your thoughts?
Yes, I'm very delighted. Am I audible to all of you?
Yes,
I'm very delighted to be part of this course. This course is just beyond explaining in the words, and I have joined this the Medi classes right about 2 years back, and I'm among the first pediatric endocrinologist FCPS cohort of Pakistan who passed this exam, and I totally give the credit to Sir Anurag and the course, which is so concise, so practical, and to the point, which clear your concepts, and it will be very beneficial for all the residents and the trainees who have joined this.
Thanks a lot, Dr. Varsha. And Dr. Jyoti, we'll have your word and we'll start the program right away from there. Dr. Jyoti?
Thank you so much, Anurag sir, and the organizing committee for giving me this opportunity. So you are one of the best mentor I have ever known. And the endocrine course which you are running, sir, it is one of the best endocrine course which I have known till now. So this course is like full of structured academics and the real life case scenario, and the modules are really very effective. So it's very easy for us to, whenever we see the cases, to like by seeing the module, we can easily manage the cases. So thank you, sir.
Thank you, Dr. Jyoti. So we'll get start with the program right away. So this is a comprehensive program that we are going to cover over a period of approximately 2 days. And this is something which is going to be covering different aspects of pediatric endocrinology over a period of those short period. And this is a practical pediatric endocrine course. So we all know that pediatric endocrinology is often considered a rare disorder which is complicated, requiring cumbersome workup and exorbitant treatments. And that's why often disorders of pediatric endocrinology are either missed or missed. And there are a lot of issues in terms of pediatric endocrinology that people tend to blame. One people talk about is affordability, that these are very expensive investigations. Doctors are not available, but actually it's the awareness which is the major factor. So if we really empower people, both the pediatricians, the trainees, as well as the general public, they will get to the doctor at the right time and they will identify. That's what we found, that awareness is the key from that regards. In a country like India, where there is a huge burden of pediatric endocrine disorders, we have got very limited number of pediatric endocrinologists which are there. So there is a need to build a pyramidal approach in which we have got referral across board, in which cases are managed and triaged appropriately, and that's why this development of pediatric endocrine resource is extremely important. We have been working over the last 15 years in different aspects of pediatric endocrinology, and we have conducted over 120 workshops, 15 practical courses, 2 postgraduate programs, and multiple advanced courses across the country. But then what we realized that it was going to be very difficult from that perspective to work off. I'll request everybody to mute themselves, please. So we have been working in different aspects. So we realized it's going to be very difficult to have physical program across the different parts. So we started off with our YouTube channel, in which we have published a number of videos which are easily available, and a lot of views have been done in that regards. Over the last 8 years, we have had fellowship programs which are there. Now we have 14 fellows till date who are there as part of our program, and many of them will be joining us. Dr. Neha, Dr. Chetan, Dr. Riddhi, Prateek, Manoj, Vibha, Dhwani, Alapan, Nimisha, Riya, all of them will be part of this program. So there are few who are busy who couldn't join, but otherwise most of them will be part of the program. Because it's difficult to have physical fellowship programs for everybody, we started off with Medi classes, which provides online resources in terms of pediatric endocrinology, including fellowship, diploma, and multiple courses. Our fellowship program is a 2-year program in which we have online and 4 on-site visits with routine assessments and options for research. Till now, 48 people have been awarded fellowships, and 72, and now the numbers have gone up, are continuing that from different parts of the world from that perspective. We've got multiple publications in pediatric endocrinology. Our mobile application, which we'll discuss about, provides a practical way of enhancing pediatric endocrine care. It's the most downloaded endocrinology app across platforms, and it has resulted in multiple publications in that perspective. We are going to launch BIG, which is bone age assisted interpretation of growth, very soon in the next month, which is going to provide direct assessment of growth, puberty, obesity, and multiple parameters on the entry of a few parameters, and you will get interpretation and likely diagnosis and assessment management from that regards. We are also working on developing personalized intelligent nutrition, which is going to guide us in terms of the nutritional requirement, assess meals, and plan based upon intelligent pathway. Our diabetes application is going to provide point of care guidance to insulin dose, glucose, activity, sleep right, and eat in terms of pediatric type 1 diabetes patients. And this is under clinical trials at the moment, and hopefully this is going to change the way diabetes is managed from that perspective. So coming back to this course, this is an extensive course, and this day is basically dedicated to office endocrinology. We'll start off with growth, followed by thyroid and puberty. So we are covering these 3 topics today. Tomorrow, we'll be covering the emergency topics, which will be there covered in the form of calcium, electrolyte, glucose, and DST, which will be covered subsequently. So we'll start off with the growth module, and the first is this case who presents very commonly, 12-year-old girl with height of 132, weight of 20 kgs. Now, we know that growth is common. Growth disorders account to 2.5% of all disorders. 80% of them are physiological. 10%, however, can be a disorder. So the key role of a clinician is to not unduly work up these 80% while not missing this pathology. So we need to have a balance between too much and too little investigations in that regards. And this is the theme of this entire practical course, is to focus investigations where needed and otherwise don't do investigations. So when you talk about growth failure, vast majority of children will have a physiological form of growth failure, which is around 80%. And typically these individuals will be short for the population, but they will be normal for the families and normal for the bone age. So whenever you want to decide evaluation, look at 3 things. Is the child short for the population? Yes. Short for the bone age and short for the family. Then only start thinking of a pathological cause, which can be an intrinsic problem, like a primary problem, where you can look at birth weight, facies, dysmorphism, and body proportion, which will give you a clue. And if these are normal, you start thinking of secondary causes, which basically are largely nutritional, in which the major effect will be on the weight, and endocrine, where the major effect will be height. The most important thing to look at in a short child is actually the weight and not the height. So we will use simple clinical clues to reach the diagnosis in these regards. So the questions that a pediatrician has to answer is it really short stature? If it is short stature, is it physiological or pathological? Is it primary or secondary? And finally, whether it is nutritional or endocrine. Now, the first question is it really short stature? So how do you define a condition like short stature which doesn't have any evident problems or evident complications in that regards? So in this study, we really looked at the chances of pathology which are there with regards to the likelihood of pathology as a marker of need for evaluation. And what we found was that height SDS was an excellent discriminator. So if the high standard deviation score is less than -2, the chances of pathology are very less. -2 to -3, they become 43%, and beyond -3, they become 80%. So what it means is that if your child's height is actually less than -3 standard deviation score, that's a red light. You have to definitely evaluate. More than -2 standard deviation, green light. Don't do much workup. And -2 to -3 is somewhere you can decide to wait and watch and observe from that perspective. The other thing to remember is to look at the chart, and for Indian scenarios, and probably wherever the local charts are available, they are better. We conducted a study in the field as well as in the clinic, and what we found was that if we compare the charts in terms of the IAP chart and the WHO chart, the WHO chart will be over-diagnosing short stature in our setting, because you will basically be saying that everybody is short, but most of them don't have a pathology. So what it means is that we should use local IAP chart. They will be better in identifying growth failure. So when do we call somebody short? I gave a simple example of height SDS below -2 to -3. But if you look at the chart, if you have a child like this, definitely everybody knows evaluation is required. Very short, height below first percentile. Second scenario, the child is just below the chart. Now, do we need to evaluate? The option is to follow up. So height SDS -2 to -3, follow up and see how the child is growing. And if the growth velocity is less, which by definition is less than 25th percentile for the age, this is short stature. But sometimes children may come to us with history of growth failure while they are still in the normal range. So in this scenario, if they are crossing 2 or more percentile lines between the age of 2 years and puberty, that is something which we have to worry about. I have very specifically talked about 2 years in puberty. Less than 2 years, you may have a physiologically appropriate catch up or catch down growth which does not require evaluation. Similarly, in puberty, you may have CDGP and you may fall percentiles, or you may have early puberty, you may grow quicker. Don't worry about that, but 2 or more percentile lines between the age of 2 years and puberty is something which is significant. So very short, short, not growing and not growing at all, these children will definitely require evaluation. Now, next question is it physiological or pathological? To answer that, you have to look at 3 things: growth chart, pubertal status, and bone age. And without this, no evaluation is possible for short stature. So in growth chart, again, look at 3 things. Look at the absolute status, what is the percentile, and we prefer height standard deviation score because that gives us a better picture. The second is what is the parental expectation, and we all know for that we calculate target height, which is father's height plus mother's height divided by 2. Add 6.5 centimeters for boys and subtract 6.5 centimeters for girls, and you calculate target height standard deviation score. One measure which is a very good marker of familiar short stature is actually corrected height standard deviation score. So if the child's height standard deviation is within 1.5 SD of the parents, that means this is a familial. So if the corrected height SDS is more than -1.5, this is familial and we don't need to bother about from that regards. Finally, to look at nutritional effect, we can look at the height age and weight age. If you have a short and lean child, that is nutritional; short and plump child, that is endocrine. And one parameter which we found is BMI SDS. If the BMI SDS is less than -1, that is looking like a nutritional cause. More than -1 is looking more like a endocrine cause in that regards. Puberty, absolutely important. Just remember 2 pubertal stages in girls. Breast stage 2, which is papilla elevation, which means that now the growth acceleration will start, the growth spurt will start, and from here the girl will gain around 20 centimeters. A lot of girls are now coming to us with complaints of breast development when they actually have lipomastia. So in this scenario, all you need to do is to just palpate for the breast nodule. If you are able to approximate your thumb and finger and there is no resistance, that is fat. If there is resistance, there is a breast tissue. Second stage to remember is breast stage 4, which is secondary mount. From here, the girl will grow only 10 centimeters. and from menarche they will grow 5 to 8 centimeters. So whenever you have a short girl, look at what the breast stage is. 135 centimeters at B2 means 155 at the end. 135 at B4 means 145, and 135 at menarche means 140. So it's not just the current height and age, the pubertal status is very, very important. For boys, look at testicular volume, and if the testicular volume is around 4 ml, you can wait and watch. Above 10 ml, urgent action is required. Beyond 15, nothing much can be done. So very important, B2 is like T4, TV10 is somewhere like B3, B4, and voice change, spermarchy, these are like menarche. So this is, I'm giving a sort of an analogous picture as far as the girls and boys are concerned. Now, another very important part is bone age. Now, what you need to remember is that for bone age, the maturation starts from proximal to distal, and fusion starts from distal to proximal. So if you want to look at the bone age, look at these distal bones first. That will give you the best idea in that regards. Only for younger children do we rely upon carpal bones, and radius ulna also are a late sign. So the most important in our regression analysis, the most important bone is the middle finger, middle phalanx. 95% accuracy you can get by single image also. That's something which is there. Girls have higher estrogen levels compared to boys, so they have a more advanced bone age. The most important thing to look at is the comparison of epiphysis to metaphysis. If the metaphysis is smaller, age will be lower. If it goes bigger and capping, it becomes more. We have got multiple videos on bone age available on YouTube. We don't have that much time to discuss here, so you can go about in that. But if you want to get one message, compare epiphysis and metaphysis and you will get the right picture. Now, whenever you get an X-ray, often people cut off the fingers, which doesn't make any sense because that's the most important part. They should be widely spread and the exposure should be fine as well. And with age, you can decide about which bone ages to look at. So in infancy only, you can look at carpals, where hardly we do a bone age. For toddlers, we can count the numbers, but from pretty much 2 to 12, 13 years in girls and 3 to 14 years in boys, all you have to focus is epiphysis and metaphysis. Very small metaphysis, this is like 4 years. It goes increasing, becomes equal by around 8 to 10 years, bigger and capping by 10 to 14 years. So if you focus on single bone, you will know radius ulna and long bones are more for fusion perspective. Now there are options available in the form of GP Atlas, Tanner Whitehouse and Bone Expert. Many of them require a lot of training, a lot of time and a lot of money. So this is something which we don't have often for a pediatrician perspective. So there is also a lot of factors from that regard. So that's why we developed our Mediclasses bone age application, in which all you have to do is to compare the bone age sites with the multiple images which are available. There are 5 sites. Compared to the Tanner Whitehouse, you will be able to save a lot of time and you will get a good amount of bone age results from that perspective in that regards. This tool has been shown to be quite effective with minimal variation as compared to gold standard and also effective for the non-expert. So this is something which we want to, and this has been used also extensively. We are also developing, or we have developed in collaboration with IIT Kanpur, a novel AI-based method in which all you have to do is to put the image and you will get a sort of a variation of around 0.8 years, which is around 7 to 8 months, with a very acceptable one, as good as an expert. So this is something which we are going to work out, and this is going to come out also soon from that regards. So if you want to differentiate physiological, pathological, you have to look at the bone age, the growth chart and the pubertal status. Now, if the corrected height SDS is more than minus 1.5, this is familial. If the height SDS for bone age is more than -2, this is constitutional delay of puberty and growth. So a child who is normal for the population, normal for family, and normal for bone age is physiological. 85% of pediatrician referrals are done out there. Otherwise, they are pathological. So look at the faces, look at the body proportion, look at birth weight. Now, nutritional and endocrine, I always talk about how weight is important. So if you have a chart like this, predominant weight effect, this is a nutritional pattern. And if you have a chart in which the height is more affected, this is an endocrine pattern, short and plump, and BMI standard deviation score less than -1 is the criteria to assess from that regards. Now, what do we do in terms of workup? So clearly look at growth chart, puberty and bone age, which are the most important investigations. Unless you have made a growth chart, do not write any investigation in a child. Look for faces in proportion, ask for birth weight, karyotype in all girls, but don't do in all unless you have excluded other causes, then you do a karyotype because cost will become more. Consider genetics, which we are doing more often now in SGA, skeletal survey, basic workup like liver, kidney and celiac. Celiac we call about in everybody, even if you have a normal nutrition. Blood gas if they are clinical features of RTA or the age is less than 3 years, and fecal calprotectin for inflammatory bowel disease after 10 years of age. Endocrine workup we recommend in everybody, FT4 and TSH, other workup only if it is required from that regards. So everybody you should do a CBC, ALT, creatinine, TTG, thyroid profile, and if needed you can do karyotype in girls, blood gas before 3 years, calprotectin above 10 years, and growth hormone and IGF-1 only once everything is normal. A word about GH and IGF-1 axis, if you want to waste your money, do a basal growth hormone, because basal growth hormone is not reliable. Growth hormone is a pulsatile hormone, it's a waste of money. So best to do a stimulated growth hormone, which is a gold standard. Remember, if the thyroid axis or the cortisol axis is affected, your levels will not be appropriate. And very importantly, in close to puberty age group, you should do a primed growth hormone assessment, which should be done in that regards. Screening tests like IGF-1 and IGF-BP3 are there, but IGF-1 in particular is nutrition dependent. So in malnourished children, they are not going to help us at all. And in liver disease, the levels may also be abnormal. So how do we approach growth failure? First question is short or not. Height STS above -2, don't worry. Forget it. If the child is short for the population, is he short for the family? So corrected height SDS more than -1.5, familial. No investigations required. Now the child is short for the family, is he short for the bone age or not? So height SDS for bone age above -2, again no workup. This is CDGP, follow up in that regards. If the child is short for the population, short for the family, short for the bone age, then you do your screening investigation, which I've discussed already. And then you decide about need for follow-up. Or if child is very severely affected, like less than -3 standard deviation score, forget about everything, start working up, because 80% pathology is already likely in that regards. Now, if you find syndromic features, you can manage. Otherwise, you do IgA to rule out IgA deficiency in the setting of celiac, and karyotype. If normal, then you do a growth hormone testing to identify the diagnosis in that perspective. So this is how we should approach. We have incorporated all this as part of our growth interpreter, where all you have to do is to just put some data, put the information about what is the current height, what is the date of birth, and once you put those data, you will be able to identify the correct diagnosis in that perspective and evaluation. We've already incorporated in part of BIG, which we're discussing, in which you will get guidance with regards to what is the growth and puberty evaluation and how do we follow up from that regards in a detailed fashion. And this has been shown to substantially improve the concordance at the level of a pediatrician and a pediatric trainee. So now we will move forward with regards to the aspects of growth evaluation. And we will be discussing now with regards to the various aspects of using a case scenario based approach. And for that, I will now invite Dr. Alapan, who will be carrying forward with regards to the further talk and the case scenarios. All of you are requested to put your options in the chat or Q&A, where we'll be addressing the questions after the sessions are going to end out from that regards. Okay, Dr. Alapan.
Sir, good afternoon, everyone. I'll start with the cases.
So this session, the experts who will be part of our session will include Dr. Chetan Dave, who is a fellow in pediatric endocrinology at our institute. Dr. Vishnu Agarwal, who just we introduced, Professor of Pediatrics at SMS Jaipur. Dr. Manisha Maurya, Professor of Pediatrics at Prayagraj. And Dr. Santosh, who is Associate Professor of Pediatrics and Government Medical College, Tirunelveli, Kerala. So Dr. Alappan, you can start off.
First case, a 12-year-old girl child with a short height of 132 centimeter and weight of 28 kg. Father height was 164 centimeter and mother's height was 151 centimeter. Dr. Chetan sir, I would like to know this approach up to this case.
Your voice is not audible, Dr. Alapan.
Yeah. So I'll again repeat the case. The case number 1, a 12-year-old girl child presented with a short height. Am I audible?
Yes, right now I can hear you.
Okay, sir.
Bol.
The height is short, 132 centimeter, and weight is 28 kg. The father's height is 164 centimeter and mother height was 151 centimeter. So Chetan sir, I would like to know your approach in this case.
So first of all, any growth or statural concern patient should be measured properly, and then we should plot them on the growth chart, number 1.
Yeah.
Yes. So we have plotted the growth chart here, and this is the mid-parental height.
Fine. So we have plotted the girl's height as well as MPH. So looking to the mid-parental expectation, the girls fall well within the normal range as far as the parents is concerned. But still, this girl is short for the population, but she is normal for the family. So then next step I would like to go for is to do the pubertal examination as well as to look for the bone age to see how much height potential is left.
So the height age and weight age of this child was 9 years, and the bone age is same,
Yes.
the almost 9 years.
So definitely she is a familial short stature. So we should explain them regarding the.
Okay. So on follow-up, this child, we are follow-upping the child, and on the follow-up after 6 months, the child's height land up to 135.5 centimeter. So Dr. Chetan said, do you think the child is growing properly, or she is still short?
So her growth velocity is fine, but definitely we should be looking into the context of pubertal development, whether she is going through the pubertal spurt or she is just growing normally without any pubertal spurt. But definitely this growth velocity is looking fine as far as the overall growth is concerned.
So Chetan sir, I would like to know what are the practical points you should give to our audience.
Yes. So definitely whenever any patients come with the height concern, definitely number 1 is to plot them on the growth chart. Number 2, derive mid-parental height. And if the child is within the parental expectations, then definitely she or he is growing well for the family. So no extra investigations is required as far as the parents are satisfied with the height of the child. Nowadays, we know that the growth velocity is also crucial. So definitely we should observe these kids for next 6 months, and we should decide if growth velocity is faltering, then definitely we should be now doing workup as far as the know the cause of the growth faltering. Otherwise, no workup if the child is falling within the familial expectations, and follow up to see the growth velocity to decide the further actions to be taken at that point of time.
So moving on to our next cases, case number 2, a 13-year-old boy child, height of 135 centimeter and weight of 30 kg. This time father's height was 169 centimeter and mother's height was 156 centimeter. So Dr. Manisha ma'am, I would like to know your opinion regarding this case.
Thank you, Alapan. I think for a 13-year-old by height of 135 and weight of 30 kg seems to be normal. So if we plot it, we see that father's height and mother's height are good. And if we see the MPH of this child, maybe the child is below the parental expectation. I think MPH is around 167. So the child is a 13-year-old boy. He's looking below the parental expectation. Now I would like to know what is the pubertal status of the child and what is the bone age of the child.
So bone age you can
Since the
see
child
from
is
the
below the
graph.
parental expectation.
Yes, ma'am. So the bone
What
age
is
you
the
can see
pubertal
from,
status?
Pivotal status is testicular volume. He is still P-pivotal, 3 ml of testicular volume. And bone age you can see from the chart, it is around 11 years.
Okay. So bone age is 11 years and the child is pre-pivotal. So it could be since the bone age is not very less than height age, and bone age is the height STS is not less than -2 as compared to the bone age. So we will consider it as constitutional and will then follow the child for the growth velocity. And since there is delay in puberty also, and the bone age is not very less for the height age.
Okay.
So we'll make it as a case of constitutional delay and we'll follow for the growth velocity.
Yes.
We can also do further assessment if we have any doubt. If the growth velocity comes to be below normal, then we can do further assessment.
Okay, we have done some further assessment and the screening tests were almost normal. And a basal growth hormone done by outside by a pediatrician was low in this scenario.
So as told by Dr. Anurag sir also, that basal growth hormone has no value in this. And even after growth hormone stimulation, we can see that the growth hormone, peak growth hormone is less. It is around only 6.2. But this test may not be true because in boys more than 11 years and girls more than 10 years, we have to do a steroid sex hormone priming before doing a growth hormone stimulation test, either by estrogen or by testosterone in boys. We have to do it before the growth hormone stimulation. So what after priming, the reports as we can see is 15.2, which is totally normal. So baseline growth hormone has no role, and in peripubertal children, we have to get a priming done before doing a growth hormone stimulation test.
So we followed up the child and we can see the growth velocity here. Ma'am, what will be the
when the
clinical
child
practical?
achieves puberty, the child achieves the height also. So practice point is before labeling a child as pathological short stature, either we have to see whether the child is in the parental expectation. If the child is in parental expectation, we will see the bone age. And if the child is below the parental expectation, still it can be physiological, it can be constitutional delay of growth and puberty. For that, we have to assess the pubertal status and the bone age. If the bone age and the height age are corresponding, it is no much difference between the bone age and the height age if it's less than -2. And puberty is still not achieved, we will consider it as a CDGP. And baseline growth hormone testing has no value. And in peripubertal children, it has to be done after sex hormone priming.
Okay, so moving on to the next case, a 15-month girl child, birth weight of 4 kg, large for gestational age, mid-parental height of 150 centimeter, presented to us with failure to thrive and diagnosed RTA by a practicing pediatrician. So Dr. Santosh sir, I would like to know, do you agree with this decision or do you like to further work up on this case?
Good evening, everybody. It's a great pleasure to be a part of this wonderful program and in the esteemed panel. So in this case, this child is a 15-month-old girl and is born to a diabetic mother. It's an infant of diabetic mother, weight of 4 kg, and the MBH was around 150. So the child at birth, the child percentile was around 95%, and while tracking the growth chart, we can see that it is catching the crossing down have been seen so many percentiles and reaching up to around less than 10th percentile. So it shows that, and the MPH is around the 5th and 10th percentage. So the most important is comparing with the parental expectation MPH. So it shows the catch down growth mainly.
And he was investigated outside, and there was base excess of -7 that has we found, and someone leveled this child as RTA. So, Dr. Santosh sir, do you agree with this diagnosis or not?
This is a mild acidosis, and usually in RTA you see the weight is significantly lower than the weight we have seen here. Usually they will be more affected. So with the child weight is within the parental expectation. The height is within the parental expectation.
So, sir, what would be your practice points in this cases? In this case.
So this is a classical example of how the height is affected by the intrauterine environment in utero and the first 2 years, and the genetic potential. So the size at the birth is affected. In this case, due to the hyperinsulinemia affecting on IGF-1 receptor, the length was more at birth, and later the child turned into his genetic potential, and switching over by 2 years, the child come to his genetic potential.
Okay, so moving on to our next case, a 10-year-old girl child, height of 120 centimeter and weight of 15 kg, and diagnosed as a case of GSD. So, Dr. Vishnu sir, I would like to know how would you like to approach this case, or the diagnosis is correct or not?
First of all, I want to see the growth chart of this patient, and kindly show me the growth chart. What we can see from this growth chart is that weight age of this child is 5 years, height age is 7 years, and chronological age is 10 years. So we can see that weight age is more affected than the height age and the chronological age. So anthropometry of this child is suggestive of nutritional cause of growth failure rather than endocrine cause.
So, some
So
investigation has been advised, and these are the reports. Sir, I would like to interpret these reports, and how would you like to proceed further?
while evaluating a case of short stature with probable nutritional etiology, we would like to do first some screening investigation in form of CBC, urea, creatinine, thyroid function test, and TTG also. What we can see that TTG IgA is mildly positive and IGF-1 is low. As I have pointed out in this case, is that anthropometry is suggestive of nutritional cause of growth failure rather than the endocrine cause of growth failure. So while evaluating a case of growth failure, first of all, we should look at the anthropometry and do not go straight forward on the endocrine assessment like growth hormone stimulation test. Golden rule for the assessment of growth hormone is that we should have suggestive anthropometry, which is not in this case. So we should go for the nutritional cause of growth failure. Second thing is that basal growth hormone is not have any value. And third thing is that assessment of growth hormone has so many variability. Is it depends upon the age as well as on the nutritional factor. Sometimes what we see that in case of nutritional cause of growth failure, TTG IgA is negative because of associated IgA deficiency. So if we have a strong suspicion of nutritional etiology, we should do IgA level and duodenal biopsy also if we have a strong suspicion. Because of associated IgA deficiency, TTI IgA may be negative. So in this case, IgA was undetectable and duodenal biopsy was suggestive of villus atrophy, which goes in favor of celiac disease or nutritional cause of growth failure rather than endocrine cause. So we have to put this child on the gluten-free diet, which shows dramatic improvement.
Okay, so sir, what would be your practice points regarding this case?
In case of growth failure, we should first do the anthropometry. If anthropometry is suggestive of endocrine cause, then we should go for endocrine assessment. Otherwise, we should look for nutritional cause of growth failure, like in this case. And if we have strong suspicion of nutritional cause, we should do IgA level along with TTG, IgA, and if possible, duodenal biopsy also. We should not opt for the growth hormone stimulation test in case of nutritional cause, because IGF-1 level is dependent on the nutritional, and there is no role of basal growth hormone stimulation.
Okay, so moving on to our next case, 80-year-old boy, height of 100 centimeter and weight of 18 kg. And in contradiction to the previous case, this time the child was diagnosed as a case of celiac disease. So Dr. Chetan sir, I would like to know, how do you like to approach this case?
First of all, if it is a known case of celiac, then I would like to definitely review the reports as well as if at all biopsy has been done or not. Okay, so this is a growth chart. So growth chart is showing that child is even more short. Weight is not that affected as compared to height, though both is affected. So definitely celiac is a chronic disease in which weight is generally more affected than height. So this particular picture looks like more of an endocrine cause. So definitely, first of all, I would like to see whether the thyroid function and all other endocrine tests has been done or not. So this is a TSH and growth hormone. Growth hormone must be random or basal level. Definitely one investigation missing is free T4. So definitely, if at all the free T4 low with normal TSH is also suggestive of central hypothyroidism. So definitely, first of all, we would see if the child fits into the central hypothyroidism or not. So has free T4 been done?
Free T4 has been normal in this case, and based on this TTG level, which is mildly elevated,
yes,
the diagnosis was done as celiac disease.
Yes.
But there was no response to the gluten-free diet.
Obviously,
so, sir, how would
yes.
you like to approach from here?
Yes. So first of all, I would like to see the free T4 level. This TTG might be a mild elevation. It may be false positive. So first of all, I would not like to stamp this as the celiac disease. Definitely, this is looking like an endocrine cause. So if free T4 is normal, then I would like to go for proper growth hormone stimulation test to see whether it is isolated GHD or it is a hypopit with central hypothyroidism and growth hormone deficiency as combined. So again, this looks like an endocrine cause more as compared to the nutritional or any chronic disease which is leading to this kind of growth failure.
So as excellently explained by Chetan sir, that this more look like an endocrine cause, and we further worked up this case, and
Biopsy would
these
be
are the
normal,
biopsy
yes.
report of our case. And also we have done growth hormone stimulation test in this case. So this is a case
Yes.
of growth hormone deficiency, endocrine pattern, rather than a celiac disease. So Dr. Chetan sir, I would like to know, how do you like to approach a case of celiac disease according to the recent guidelines, and what would be the practical points that you keep in front of our audience?
Yes. So any child with a growth failure, we should be doing TTG as a part of routine screening investigation. If TTG is normal, mostly we do TTG IgA. If at all we are any skeptical, then we can go for IgA level along with the TTG IgA as well. If TTG is negative, then definitely celiac is excluded. TTG is borderline or up to the 10 times of upper limit of that lab value, then we should be going for the biopsy, that is D2 biopsy, in which Mars classification is used nowadays. Any classification above stage 1 is called a celiac, and then we should be putting them on the gluten-free diet, and we should be using the word gluten sensitivity or hypersensitivity as compared to the allergy, because this is not a routine allergy which vanishes off. Of course, the child has to be on the gluten-free for very, very long time, preferably lifelong, and about 10 times upper limit, then there is no need of biopsy if anti-endomysial antibody is positive. So overall, any positive TTG should be looking towards the biopsy. Practical points again same. Short and plump child, go for endocrine causes. If the weight is more affected, then you should be ruling out all chronic diseases. And biopsy is must to rule in celiac disease, to diagnose the celiac disease.
Thank you, Chetan sir. I would like to go further for the next case, the case number 6, a 6-year-old boy with height of 90 centimeters and around 2 years of height age and weight of 12 kg and diagnosed as a case of nutritional rickets. He has been given multiple doses of vitamin D by practicing pediatrician and there was no response. X-ray showing suggestive of rickets. These are his calcium and alkaline phosphatase and other electrolyte profile. So, Dr. Manisha ma'am, do you agree with this diagnosis of nutritional rickets in this case? And how would you like to proceed in this case?
No, I think it doesn't go with nutritional rickets since multiple doses of vitamin D has been given and still there is no response. So if there is no response, we have to think about refractory rickets. And X-ray is also suggestive of rickets, so we have to go for the assessment. First, we have to see the phosphorus level. If the phosphorus level, any child with refractory rickets, we have to look for the phosphorus level. If the phosphorus level, go to the backslide, Alapan.
Yes.
If the phosphorus, we can see that the phosphorus level in this is 4.2, which is normal. So if the phosphorus level is low or less than or normal, then we have to get the first investigation that we have to do is a ABG. So in ABG, what is the finding ABG in ABG?
This is the ABG findings, ma'am. pH was 7.1 and base excess was minus 15 in this case.
Yes. So the pH is 7.1. Obviously, there is acidosis. Bicarb is 8 and base excess is minus 15. So if base excess is less than minus 5, we have to contribute this as metabolic. So this is a metabolic acidosis. Then we have to look for the anion gap. So what is the anion gap of this child? So we see that the anion gap is 12, which is normal anion gap. So normal anion gap metabolic acidosis, one thing which comes in mind is renal tubular acidosis. So for renal tubular acidosis, we have to confirm the findings that is it really renal tubular acidosis. So we will get the urine examination done. We will do the urine anion gap. As you have already shown that urine anion gap is positive. So it goes more in favor that this is renal tubular acidosis and urine pH is 6.8, which is more going towards alkaline side. So it can be a distal type of renal tubular acidosis. And urine, the other investigation to diagnose, confirm RTA is urine to blood carbon dioxide difference, which is 10. And initially also in the electrolytes also we have seen that the electrolyte, there was mild low potassium also. Go to the first slide. I think it was the indicator. It was also the indicator that the potassium was mildly low. That also indicated that it could be RTA. So always think of RTA in a child with refractory rickets.
So ma'am, what would be your practical points regarding this case?
So the practical points is a child coming with refractory rickets and growth failure. We always have to think. So first investigation in refractory rickets is to look for the phosphate level and electrolytes level. If the phosphate level is low or normal, we have to get the ABG done. And if the electrolyte in this case, the clue was low potassium also. In RTA, the potassium is low. And if the phosphates are towards the higher side, then we have to do the kidney function test first. So in this, the phosphates were normal, though we did the ABG. If ABG is showing acidosis, then we have to get the anion gap. If it is normal anion gap metabolic acidosis, most likely it is RTA.
Okay, so moving on to the next case, case number 7, a 14-year-old girl with short height, 120 centimeter and weight of 32 kg. With a normal screening profile. Dr. Santosh sir, this is the picture of this girl child who presented to our OPD. I would like to know how would you proceed in this case? Dr. Santosh sir?
Dr. Santosh, there might be some
can you hear me? Alapan, can you hear me?
Yes, sir.
Yes, yeah. Since this screening and all is normal and the child is too short for her age, And since this child is a girl child, I will look for any clinical features of Turner's. And if the child had a wide carrying angle, brachymetacarpia, and features like that, I will think of Turner. First, I have to rule out Turner in this child. And some if, since this child is pubertal, it come with an FSH. Somebody had done a value of FSH, and the FSH show 72 micro units per liter is too high. So it's an indirect, there is no feedback inhibition from the ovary, estrogen from the ovary. So we will strongly think it's another surrogate marker for Turner. I would suspect Turner in this child, but before labeling this as Turner, I would like to do. I want to see the karyotyping of this
Yes.
child.
So karyotype has been done, and these are the clinical pointers that you are looking for, sir. Karyotype was in this case X0 in this case. So,
Okay.
sir, what
So
would be your practice point in this case?
yeah, the important, I'll stress one more point in the karyotyping is, even though FSH is high, karyotyping is very important, because sometimes the Turner mosaic may be may be there with the XY line or cell lines also. So there is always a risk of gonadoblastoma in these children. So that needs surgery. For all Turner, with clinical stigmata and raised FSH, it is mandatory to do karyotyping. And next, once you diagnose the case of Turner syndrome, you have to rule out all the associations, mainly coarctation and other hormonal status. Also, you have to look into it, because hypothyroidism, autoimmune hypothyroidism, is much common among the Turner, and like that, diabetes, celiac disease. So many autoimmune conditions are also associated with that. And uh, next, I would like to, after screening the association, I would like to, one more comment I need to tell is that don't do growth hormone stimulations test in these children. If you do growth hormone, it comes at mildly low or normal, but no point in doing growth hormone assessment in these children, because this Turner, there is no problem with the GHRH growth hormone IGF-1 axis. The problem is with the SHOX gene deletion. That is all haploid SHOX gene is there. That's the reason they are short. Okay.
Oh, thank you, sir. So
Yeah.
I'll move on to the next case, case number 8, a 5-year-old boy with birth weight of 2.1 kg. He was having a poor growth but normal development. Height was 90 centimeter and weight is 10 kg. This is the growth chart of this child. So, Dr. Vishnu sir, I would like to know how do you like to proceed in this case?
This 5-year-old child present with a significant growth failure with height of 90 centimeter and weight of 10 kg at the age of 5 years. What is peculiar in this case is that birth weight of this child was 2.1 kg. So it was SGA baby, not the AGA baby. So show me the growth chart. Most of the SGA baby show normal catch up to the maximum up to the 2 year, and few of them show catch up to also 4 year. If they are not going to get catch up by 4 years, they are not going to grow and they will remain short. Another thing is that besides the normal catch up, this SG baby show two other type of growth pattern. They may show rapid growth and they ultimately land up in the tall, but they were metabolically unhealthy, or they may show failure of catch up and they ultimately land up short, but they are healthy. So SG babies show maximum catch up to the age of 2 year, not beyond that. So we have to follow them up for the growth on the growth chart, and simultaneously we should also rule out other etiology for the growth failure. And if they don't show catch up by 2 year, we have to start the growth hormone, and there is no need of growth hormone stimulation test in these patients.
So, sir, what would be your practice points to our audience?
Monitor the patient for growth failure on the growth chart, looking into consideration their birth weight. If birth weight is low, they are not going to show catch up beyond 2 years. Simultaneously, we have to rule out other causes and treatable causes and nutritional cause. And if there is no treatable cause, we have to start growth hormone without growth hormone stimulation test, because there is no need of growth hormone stimulation.
Yes, sir. So moving on to our next case. Thank you so much. This 10-year girl child with height of 112 centimeter and weight of 24 kg with a normal screening profile. Dr. Chetan sir, this is the picture of this child. I would like to know how do you like to diagnose this case, or how do you like to approach this?
Hello.
Case? Hello, sir. Am I audible, sir? Hello.
Hello. Am I audible?
Yes, sir. Yes, you are audible.
Ah, yes. So this is a 10-year-old girl with very short stature with a normal screening investigation, but definitely she has got lower limb defect, and we should be doing X-ray, as well as we should be looking for the rickets profile first.
Okay, sir, we have done X-rays and other investigations, and we have also goes for the anthropometric measurements.
Yes. So she has got upper segment, lower segment ratio, which is called as disproportionate. So definitely she is a case of disproportionate short stature.
And sir, the mutation in this case
And
the diagnosis?
Yes, so FGFR mutation, which is typically associated with the long bone shortening. So this is achondroplasia versus hypochondroplasia, leading to the short stature.
Thank you, sir. What would be your practice points for our audience, sir?
Yes.
Chetan sir, what would be your practice points towards our audience?
Yes, so practice point will be, we should be looking for upper segment, lower segment measurement if at all we find it useful, because many disproportionate short stature are associated with genetic mutations in which not much screening investigations or any other thing needed. So nowadays growth hormone may be tried in few mutations, but still there is no need of extensive testing if we find disproportionate short stature with classical signs of hypochondroplasia or achondroplasia on X-ray.
You, sir.
So we'll now move forward to the second aspect of growth disorder, which is now becoming more common, of obesity. So this is a 16-year-old boy who is presenting to us with significant obesity. And what we are seeing here is that most children with obesity, 98%, do not have an underlying cause. Only 2% have a pathological cause. So it's much more common to have a physiological cause in obesity. So we need to be even cautious when we do a diagnostic evaluation. The key pointers of physiological ones, which are 90%, is normal growth, normal development, and normal puberty. So if these things are normal, do not need extensive workup from that regards. Genetic causes like syndromic and monogenic will have soon severe segregating and syndromic features. So hyperphagia, vision abnormalities, pubertal abnormalities. Drugs like valproic acid, steroids, and hypothalamic obesity again will have hyperphagia. Endocrine causes are not uncommon, and we can often have mild elevations of TSH, which are not the cause but the effect of obesity. They will typically have growth and pubertal delay. So in our algorithm which we have developed, we first look into the obesity criteria, and in young children, if the body mass index or the weight for height SDS is much higher, we start thinking of a genetic study. Similarly, in older individuals, in the presence of syndromic features like developmental delay, vision abnormalities, or dysmorphism, we go for genetic studies. Otherwise, if they are normal and short stature is present, we think of endocrine cause, while otherwise we just recommend a complication screening, which is essential for everybody, including a fasting 2-hour glucose levels, ALT levels, lipid profile, which becomes important. So obesity criteria, age, and clinical features will give you a clue, based upon which we have developed an obesity interpreter, which is providing us with information about the likely cause of obesity with a high degree of concordance with the clinician's diagnosis, around 90% cases in that regard. So Alapan, we can start off with the case again. Yeah.
So moving on to the next case, a 12-year-old boy presented with obesity. Height was 160 centimeter, normal height, weight of 70 kg. TSH was 7.91 and he was advised thyroxine in this case. So Dr. Manisha ma'am, do you agree with this diagnosis of subclinical or rather acquired hypothyroidism in this case?
No, I think Alapan, you already told that height is normal. So if height is normal, so we should not think of thyroid hormone deficiency. And since TSH is only mildly raised, in obesity there is increased leptin in the body, and this leptin go and stimulate the TRH hormone. It is just a compensation for or a defense mechanism for our body to increase the energy expenditure. So there will be only mild increase in TSH in response to increase in TRH, which is increased by increased leptins in the body. So this mildly raised TSH is not the cause for obesity, it is the effect of obesity per se. So this child shouldn't be advised thyroxine unless the TSH is more than 10 or the TPO antibody is more than 3 times.
So moving on to my next case, a 12-year-old girl child, height of 130 centimeter, quite short height, and weight of 58 kg. She has been investigated from outside and reassured by a practicing physician that it is a normal obesity. But currently, she has presented to us with rapid weight gain. Dr. Santosh sir, I would like to know how do you like to approach this case?
So, this 12-year-old girl child had a height around 130. She is short, and she's in the obese range of weight-wise. So I will thought a short and obese child. I'll think of endocrine causes first. I will first want to see the growth chart, and then I want to see her. I want to do a clinical examination, because the one thing which we have the endocrine causes here are, one is growth hormone deficiency, hypothyroidism, then Cushing syndrome, pseudo hyperparathyroidism. These all children are short and plump children. So I want to say, if photo is available, I need to see her photo. One thing which I can so this child looks to be have a Cushingoid feature. I want to know whether there is any drug intake, steroid intake, or any form of steroid the child had taken to rule out exogenous Cushing.
She has history of she doesn't have any
No,
drug
no
in
history.
no history, and the
Yeah. So the one thing, yeah. So the child is I should to rule out exogenous and endogenous Cushing. I need to do a 8 a.m. cortisol level, and if 8 a.m. cortisol is low, I think I'll suspect the suppression of HB axis, and it could be an exogenous Cushing. Since there, then I'll do an overnight dexamethasone suppression test, and if it is more than 50, I will it's a screening test for Cushing syndrome. And one more the clue in this thyroid profile is that the TSH is slightly suppressed. In hypercortisolism, usually TSH will be slightly suppressed, because the steroid cortisol will directly act on the TSH and suppress the level. So this is a case of Cushing syndrome.
Thank you, sir.
Yeah.
Moving to our next case, and the last case, 3-year-old girl child with rapid weight gain, height of 84 centimeter and weight of 26 kg. She has severe hyperphagia that is present since birth, and every screening test that has been prescribed to her was normal. So she has any other kind of normal development, vision was normal, and there is history of infections. So Dr. Vishnu sir, I would like to know how do you approach this case? Dr. Vishnu sir, I would like to know your opinion regarding this case.
So I think by the time Dr. Vishnu joins,
This 3-year-old girl presented with the severe hyperphagia since birth and the history of the rapid weight gain. So while evaluating a case of suspected obesity, first we have to confirm whether we are dealing with actually obesity or not. This 3-year-old girl have weight for height is more than 97th percentile, so it is fitting into the obesity criteria. Second thing is that while evaluating a case of obesity, we should do a screening test and look for treatable causes of obesity, and we should also look for the red flag sign associated with obesity in form of soon, severe, segregating, and syndromic. Since this child presented at the so young age with the history of rapid weight gain and obesity, so we should look for genetic cause in this case, and we should do genetic testing. While simultaneously, we should also rule out some common causes of obesity like hypothyroidism, pseudo hypoparathyroidism, and cortisol excess. Can you let me know about the genetic testing level? This child was found leptin deficient. So, while evaluating a case of obesity, we should look for red flag sign. Is there or not? This child has soon, since she has presented at the age of 3 years. There is also severe obesity, so we should look for syndromic causes of obesity or genetic causes of obesity in this case.
So I think that's very, very clear. The 4S always holds true. Thanks, Alapan, for this wonderful discussion. And thanks, Dr. Vishnu, Dr. Santosh, Dr. Chetan, Dr. Manisha, for this interesting discussion that we have seen in that regard. We'll quickly go through the Q&A. So how do we plot the two lines of target height after getting the MPH? So generally, we will add around 6 centimeters on the top and 6 centimeters bottom, and then try to develop a parallel of that. The alternate to that will be to look at the target height SDS, which will give you the idea from that regards. So that is the answer to that. There are a couple of chat options which are there. So now I think thanks again. We are going to close our growth session. Thanks, Dr. Vishnu, Dr. Santosh, Dr. Manisha, Dr. Chetan, and Dr. Alapan for this nice discussion. And we will now carry forward with our second aspect of the talk, a very important disorder, which is about the growth disorder followed by the thyroid profile. And again, we will have an interesting discussion on thyroid. We are going to be joined by Dr. Vibha Yadav, who is currently working as a senior consultant in pediatric endocrinology at Regency. And we have got 4 panelists also in that. So before we go ahead on that, we'll just introduce the panel who will be joining from that perspective. We have Dr. Sonal Shah, who is a professor of pediatrics at MPS Medical College, MP Shah Medical College, Jamnagar. We've got Dr. Rajiv Bansal, whom we just had a discussion during the inaugural part, who is a senior pediatrician at the Sant Durlabji Memorial Hospital in Jaipur. Dr. Balaji, who is a professor of pediatrics and HOD of pediatrics at SRM Medical College, Chennai. And Dr. Rashmi Nagaraj, who is Associate Professor in Pediatrics at JSS Medical College, Mysuru. And over to Dr. Vibha for the inaugural part of that discussion.
Thank you so much, sir. And very good afternoon to all of you. Starting from the thyroid session, as we all know, thyroid functions are the most commonly prescribed by most of the pediatricians and pediatric endocrinologists. So the most important hormone in the thyroid pituitary, hypothalamic pituitary thyroid axis is the TRH, which is secreted by the hypothalamus and which acts on the TRH receptor in the pituitary and regulates the secretion of TSH. Now, this TSH further acts on the thyroid gland and on the thyroid receptor to produce the T4 and the T3. T4 is the prohormone, which is converted to the T3 by the immunodiabinase activity 1. And these both the T3 and T4 circulates in the blood bounding to the TBG. So only the free T4, that is around 0.03% in the FT4 and 0.3% of the FT3, which acts on the tissue and which regulates the function of the body. So, and this FT3, which is the most important and the active hormone, acts on the thyroid receptors in different parts of the body. Talking about the primary hypothyroidism, in this condition, the main hormone to go up is the increase in the TSH. After that, it is followed by decrease in the free T4 or the T4. And in the last, body tries to maintain the level of the T3 by activating the MDI3. So the T3 is the last hormone to fall down. So if we ask the most common and the most ideal test to be done in the primary hypothyroidism, it is the TSH and the free T4. And if we talk about the central hypothyroidism, in this condition, the free T4 goes down, but in this, the TSH does not goes as high as it increases in the primary hypothyroidism due to the presence of bioinactive TSH. So TSH either remains the normal or it increases up to 10 or 20 units. In case of the thyrotoxicosis, where there is increased production of the thyroid hormone, the first hormone to goes down is the TSH, and further, the T3 is the second hormone which increases in the level, then followed by the T4. So it is important to know what is the thyroid function test, when it should be done, and how it should be done. So in case of hypothyroidism, where the TSH is the first hormone to increase, the T4 goes down because it plays a log linear relationship where the TSH increases, it causes the fall in T4. And T3 is the last hormone to goes down. So in hypothyroidism, FT4 and TSH should be prescribed, should be ordered to any patient rather than going for the total T4, because it is only the free T4 which acts on the tissues and which has the effect. In case of the thyrotoxicosis, where there is increase in the thyroid production, the TSH goes down, followed by increase in the T4, then T3. In the cases of T3 toxicosis, the T3 goes first, rises in the level first, followed by the T4. And in cases of thyrotoxicosis, the ideal test to be done, T3, free T4 and TSH. We do not order the free T4 because of the less labile SS for the free T3. Now there is a variation, and it is important to know when should be the test be ordered. Because there is a diurnal variations in the TSH level, they are high in the 12 a.m. to 4 a.m. and they goes down between 10 to 4 p.m. So whether it should be ordered in the evening or in the early morning, this is a question. If we see there is a diurnal variation about 40 to 50%, but if we see the biological, it is around 1,000 in between the lowest and the upper limit. So it won't make any difference. There is no definite timing that TSH should be ordered either in the morning or in the evening. It can be done at any time of the day. And there is an intra-individual variation of 0.5 milliunit per liter, and individual between the two patients of the euthyroid, they can have the variability of 2.5 milli-international unit. So if we are ordering, TSH can be done at any time of the day, but we have to make it sure that pre-T4, it should be ordered before the intake of the medicine, because the free T4 will come in the blood and it will falsely elevate the free T4 levels. Now, TSH, if we see there is a huge rise, huge surge of the TSH just after the birth because of the temperature difference. Inside the uterus, baby is in cold temperature, and when the baby is delivered, he exposed to a warm temperature. So within this shift of the temperature, the TSH plays a very important role because it helps in the thermogenesis of the baby. And if we see that during the birth, it is like up to 60 or 70 international, then further with the postnatal time, it falls down. So for the estimation of the TSH, we can either collect the sample by the cord blood, but the ideal time to get the TSH done is on the day 3. But if due to any cause or due to early discharge, it is to be done in between before day 3, then we have to keep the TSH level more than the upper limit, that is around 34 or something. The higher cutoff should be made if it is done before the day 3. So there are certain TSH, this upper limits where we have to take action, like it is very easy to learn that in the first week it is 40, in the second it is 20, in the second 2 week to 1 year it is 10, and in the adults and in the children we keep the upper limit of 4.5, and we only treat the patient when the TSH level is above 10. So I have already discussed it that free T4 and TSH has a log linear relationship. It means when the FT4 goes down, the TSH will increase. And in the conditions where FT4 is low and TSH is high, that is above 20, this will be in the case of primary hypothyroidism. And where the free T4 is low and TSH is below 20, then this will be the condition of central hypothyroidism. And in the cases where free T4 is high and TSH is undetectable, then this is the case of thyrotoxicosis. And in the presence of high FT4 and detectable TSH, then this is the condition of TSH adenoma, and it is very rarely found in children. Now coming to the interpretation, because once we have ordered the investigation and we get the result, it is important how to interpret, because here is the most common mistakes have been done during interpretations by the usual physicians. So this is a very precise table and easy to learn. And if we see that if the TSH is low, FT4 is low, and FT3, all three are low, then it is a condition of central hypothyroidism. But if it could be, FT3 could be normal in central hypothyroidism. And if we see FT3 is high in the conditions where T3 treatment is used, that is the Lenormand treatment, we can find low TSH, low FT4, and high T3. In the reverse, in the cases of thyrotoxicosis, the TSH is low, the free T4 is high, and we'll find the high free T3. In the cases of T3 toxicosis, that is found in the iodine deficiency state endemic areas. In these areas, the patients have low TSH, normal free T4, and the high T3. This is the T3 toxicosis. It has to be remembered. So estimation of T3 becomes important in the cases of this T3 treatment, T3 toxicosis, and thyrotoxicosis. When the TSH is normal and FT4 is high and FT3 is also high, it could be in the TSH adenoma or resistance to TSH hormone. And if the TSH is normal, FT4 is low and FT3 is also low, then this is the condition of central hypothyroidism. And if you see the TSH is high and FT34 and FT4 both are normal, then this is the subclinical hypothyroidism. And if TSH is high and both the FT34 is low, then this is the condition of overt hypothyroidism that is most commonly dealt with us. Now coming to the neonatal screening, which has to be done in day 3, and TSH has to be taken by the blood sample. It is very important to do this neonatal screening in each and every child delivered in the hospital or outside. And there are certain conditions where we have to rescreen the TSH after 3 days. That is prematurity and the child with trisomy 21, the same-sex twin, and those child who have been hospitalized previously. So coming to the neonatal screening, the serum TSH is twice of the whole blood TSH. So it doesn't matter whether we take TSH, serum TSH or whole blood TSH. Now, if we see the cutoff, if the TSH is more than 40, then we have to repeat the FT4 by the dynamic equilibrium method, and we should start the treatment. And if it is less than 20, or if it is between 34, if it is blood is taken between 24 to 48 hours, then no treatment is required in 99.9% of the cases. But if the TSH is between 20 to 40, then definitely we have to repeat the TSH after 14 days of life. After 14 days, if it is more than 20, then again we have to reassess the FT4 and start the treatment. If it is less than 10, then no treatment is required at all. And if we are in the midway, that is between 10 to 20, then again we have to repeat the treatment after 21 days. We cannot start the treatment immediately. And after 21 days, there are conditions where the TSH is more than 20, then we have to treat the patient. And if it is less than 6, then definitely no treatment is required. And if it is between 6 to 20, this is a very dicey condition, whether to start the treatment or not. So it is better to start than do further investigation. So get the free T4 done in these cases. Scan the patient for this anatomy of the thyroid, because in the cases of hemigenesis, this 6 to 20 TSH is found very commonly, and we have to treat these patients. Now, thyroid screening in preterm is very important, and it is important to understand because it has to be done between day 2 to day 4. And if TSH is less than 10, then we have to repeat the TSH level at around 2 to 4 weeks when the baby becomes term. And if it is more than 10, then get the free T4 and TSH done. And if free T4 is low and TSH is more than 10, then definitely we have to consider it as primary congenital hypothyroidism, treat the patient. And if the free T4 is normal and TSH is less than 10, then again we have to reassess the child after 2 to 4 weeks or when the child becomes term. And if the TSH is less than 10 and free T4 is low, then we got the confusion. So we have to see either the child is presented with any MPHD features like hypoglycemia, micropenis, and if yes, then consider it as a central congenital hypothyroidism and get the MRI done, immediately start the treatment. And if there are no features, then reassess the FT4. And if it is normal, then repeat the test. And if it is low, then consider it as a central congenital hypothyroidism. Now coming to after interpretation of thyroid function test, now coming to the imaging. Thyroid scan is important and we should know when should we go for it because it is quite costly and it is not available in most of the centers. So if we see thyroid in the different location, that is between the normal location of the thyroid and at the base of the tongue, definitely it is an ectopic thyroid. And if there is an increased uptake of in the scan, then this is could be due to dysharmogenesis or iodine deficiency. And if we find there is no uptake in the scan, then definitely we should go for the thyroid ultrasound. Because if in ultrasound there is no thyroid, then definitely it is a case of agenesis. But if in the ultrasound it is present, then we have to keep our eyes and ear open and we should get the trap antibodies done. If the trap antibodies are present in the child, then this uptake is absent because of the transfer of blocking maternal antibodies to the child and they have blocked the receptors. But if the trap antibodies are negative, then the sodium importer defect and the thyroid receptor defect could be the cause. Now, I would like to invite Dr. Nimesha to start the case scenarios.
So, Dr. Nimisha, you can start the cases.
Thank you, sir and ma'am. We will start with the first case, 20-year-old girl presented with a complaint of with neonatal screening being done with high level of TSH of 28. What will be our plan, Dr. Rajiv, sir?
So now we have done the TSH of a child very early. In fact, we have learned earlier as what has been taught in these previous 15-20 minutes, that the TSH should ideally be done in a child who is at least 72 hours of age. Now, what happens is because of the birth process itself, the TRH is released and the TSH goes high, and which generally stabilizes by 72 hours. So either we have to have, if at all the child is being discharged from the hospital in early age, say 24, 48 hours, then we'll have to have a higher cutoff levels to see if that is relevant in this particular child or not. and that relevant level becomes around 34 units. If at all, one has to take it into consideration for practical purposes. If that is not the case, a repeat TSH has to be done in these children at 72 hours and then subsequently at 14 days of age. If the levels are still high, then is a time that we have to think that this child may be suffering from partial hypothyroidism and will need treatment. So we need to repeat the test. And in this particular child, the TSH at 72 hours came down to 8 mU per liter and an FT4 of 1.8, which suggests that this child didn't need any further evaluation or treatment. So the key message is that we need to screen them after 72 hours. And the TSH, if at all, one has to take a TSH levels of 34 in case you do an early evaluation. I can't hear you. You're not audible. Dr. Saab, you are not audible.
Is it audible now?
Yes, sir. Yes, sir.
Okay, sure.
Thank you, sir. Very rightly said. Due to TSH surge, we should do the screening at 72 hours. Moving on to the next question. Day 4 old child with TSH levels of 22. The repeat screening was done at day 14. Again, the TSH was high of 12. At repeat screening done at day 21, the TSH is still high, but the FT4 level comes to be the normal. Dr. Balaji, sir, how would you like to proceed this case?
Thank you, Ma. Thank you for this. So here, as per the screening results, we have the criteria which we were discussing. So at day 3 of life, if it had been 40, we are going to treat. If it is less than 20, we are not going to give any treatment. But in our child, it came out to be 22. So it's like the cat on the wall. It is not more than 40 and it's not less than 20. So at day 3, if such a scenario, we have to repeat again the values at 2 weeks. So again, we repeated the value. So at 2 weeks, if it is more than 20, we are going to treat. If it is less than 10, we are not going to treat. We are going to say it's normal. But in our child, in our baby, again, it is the cat on the wall story. It is 12. So we have to again repeat after 21 days. So we repeated it again. So by 3 weeks, if it is more than 20, then again we are going to treat. And if it is normalizing to less than 6, we are not going to treat. We are going to accept it as normal. But again, in this scenario, it is again, it's 9. So even after 3 weeks of repeated investigation, the TSH is not reducing to normal. So this scenario, something is causing the TSH to remain elevated. So we have to evaluate and see whether it could be hemiagenesis or ectopic. And so nuclear scan we have to do. And we did, and it came out to be hemiagenesis.
Yes, sir. What will be the key messages?
So here the key message is persistence of TSH beyond 6 to 20, even after 3 weeks, is a cause of concern, and we need to evaluate, especially if there is hemiagenesis or not. We have to see and manage accordingly. Even
Thank you.
T4 is normal. Thank you.
Moving to the next case, day 10 child with TSH of more than 100. FT4 was done, it was low. Scan showed no thyroid tissue. What will be the plan? Dr. Rashmi, ma'am.
Thank you, Dr. Nimisha. Actually, it's a 10-day-old child with the TSH very much elevated. and free T4 is also low. So we have to just it's a straightforward congenital hypothyroidism. We have to start levothyroxine as soon as possible without wasting time, because after 2 weeks of age, there'll be a loss of IQ points for every single minute of delay also. So we the drug of choice would be levothyroxine, and there is no role for T3 as such, and it's always prescribed in tablet formulation, because syrup formulation may be unstable. And generally, the dose considered is 10 to 15 microgram per kg per day, but still, again, it depends upon the free T4 levels basically. So lower the free T4 levels, higher the dose should be considered. And the timing of the medication should be at least 4 hours after the feed for proper absorption. Actually, based on the free T4 levels, uh, in this case, the free T4 level is 11. So we can start at a dose of 8 to 10 microgram per kg per day. And if it were to be lower, then we would start at a higher dose. And the free T4 levels need to be monitored on a regular basis to titrate the dose.
Yes, ma'am. On eventually on follow-up, there was high free T4 levels, and the dose of thyroxine was reduced, and child was eventually made off treatment.
Yeah. Here actually, on repeated follow-ups, we have observed that free T4 levels have been becoming normal, or even becoming high. So the dose also was reduced, and eventually it ended up in not requiring any treatment. So probably here we have to consider what could it be a transient hypothyroidism should be considered. And even though thyroid scan did not show any uptake, it may be important to do a thyroid ultrasound, because there could be an aberrant thyroid. So if there is no thyroid gland found at all, then we could consider agenesis. Suppose the thyroid gland is found, but there is no uptake, then we must consider TRAB antibodies. And if the TRAB antibodies are present, then probably it's the transient, hypothyroidism due to the transmission of maternal antibodies through the placenta. And if the TRAB antibodies are absent, then we may have to consider other conditions. So the most important key message in this case would be just basing our decision on the report of a scan would not be sufficient. We'll have to go ahead with a thyroid ultrasound to check whether there is really a gland or not. And if it is so, then we have to check for any antibodies, thyroid receptor antibodies. So the carry home message would be, in all cases, whenever there is a doubt, better to do an ultrasound of thyroid.
Thank you, ma'am. Moving on to the next case, a day 4-old child with TSH of more than 100. On scan, it was found to be dyshormonogenesis, was started on a thyroxine of 50 microgram. On repeat testing at 4 weeks, free T4 was 21 on the higher side, and the TSH was still on the high, free T4 on the normal range and TSH on the higher side. How will you like to approach this case, Dr. Sonal, ma'am?
Yeah. Thank you very much, Dr. Nimisha. As a child was on day 4 with TSH of more than 100, so it is definitely a case of hypothyroidism, and we have started the right drug in the right dosage. And now, after 4 weeks, we have repeated the thyroid hormone, thyroid test, and TSH is more than TSH is 20 and FT4 is 21, which is normal, within normal limit, but TSH is at a little bit higher limit. Next, please. Yeah. So usually the dose titration should be done around 2 weeks, 4 week, or 6 week after the appropriate testing. And as we have tested after 4 weeks, the FT4, our target is around it should be around 1.4 to 2.3. Here it is like normal, and TSH, our target is 0.5 to 2.0 mU per liter. Now, like, we have to interpret both, because initially it takes time for the hypothalamic pituitary axis to get normalized. So it is to becomes reset phenomenon is there. So accordingly, in initial doses, we have to titrate the dose of the thyroxine with the help of the FT4 level rather looking to the TSH level. Now, if we see the TSH level, if it is high, as it is there in this case, and the FT4 level is low, then you have to increase the dose. But in this case, the FT4 level is normal or FT4 level is high. So if it is normal or high, then you have to continue the same dose. So in this child, we have to continue the same dose, and initially for few months, we have to titrate the dose according to the FT4 level rather than the TSH level. We with TSH level, we normally monitor the level. In this case, if the patient's TSH level is normal, FT4 level is normal, then you have to continue the same dose. But if the FT4 level is high, then again you have to continue the same dose. But if TSH level is normal and FT4 level is high or normal, then you have to reduce the dose. So basically, we have to titrate the dose of the thyroxine according to our FT4 level in the initial phases of the treatment.
Okay, rightly said, ma'am. It is due to the reset axis that TSH was high. So we'll continue with this.
So we continue with the same dose. Okay.
At
Now
3
the
years
same
of
child, we assess the development of the child. And if the child has presented with a delayed speech at the age of 3 years. So whenever any patients of congenital hypothyroidism, of course, if we have started the treatment in time, we expect the normal development of the child. But there are different associations with the hypothyroidism. So hearing assessment must be done even in the neonatal period or early infantile period, because this may be association of the Pendred syndrome may be there, which is commonly associated with a hearing loss deficit with the congenital hypothyroidism. It may be there. Okay, so we have to do the hearing assessment in this child to rule out the Pendred syndrome.
Key messages you will like to give, ma'am?
Yeah. So key message is that because of the hypothalamo-pituitary axis reset mechanism, we have to monitor the FT4 level rather than the TSH in the early phase of the treatment. With the free T4 level, and hearing assessment is must in each and every case of the congenital hypothyroidism.
Thank you, ma'am. Moving on to the next case, 32-week-old neonate was on routine screening found to have TSH of 7 and normal free T4 levels. Dr. Rajiv, sir, how will you like to proceed with this case?
So in a preemie, the TSH may take time to stabilize, and so in that situation, we need to repeat the TSH level in these children at around say maybe 2 weeks of age, and or maybe when they are term, if they are preterm and nearing the term. So only at that time we'll be very sure that this child needs any further evaluation or not. So one has to be very clear and very careful whenever they are evaluating a child who is or a premature baby. So day 14, at day 14, this TSH was 14 MU per liter. So this is definitely on the higher side. And there is a delayed rise, so we need to be very careful and we need to reevaluate.
So key messages you will like to give, sir?
Delayed rise in preterm is seen for TSH levels, and repeat screen at 2 weeks return is needed in these children.
Thank you, sir.
Thank you, Nimisha. So we should always keep hypothyroidism as a diagnosis in the cases of growth failure, where the patients present with the pubertal disorders, either early or the late puberty. Sometimes just looking at the X-ray, we can think of a diagnosis of hypothyroidism if we find a cardiomegaly in the X-ray, and if the patient present with a lethargy, weakness, and on the blood investigation we found hyponatremia, then it could be due to the hypothyroidism. Any motor delay, and where the patient present with the increased acne, increased hair growth, like hypoandrogenism, then always think of hypothyroidism. So these patient may present with very subtle symptoms like fatigability, lethargy, worsening of school performance, and mood swings or emotional lability. The other investigations that give us a clue to the hypothyroidism is presence of high LDL, low HDL, high CPK level, high prolactin, because the TRH increase in TRH also increases the prolactin level. Anemia, it could be both micro and macrocytic. Hyponatremia, this hypothyroidism can present with like SIDH symptoms. And cellular mass, which is basically is due to the pituitary hyperplasia caused by increase in TRH. So coming to the approach to hypothyroidism, before starting, we should always get the free T4 and TSH level done. And I repeat, the free T4 level is important because total T4 won't give us a clue about the effectiveness of the thyroid in the body. So if the free T4 level is low, then get the TSH, then see what are the TSH levels. If it is above 20, then it is the primary hypothyroidism. And if it is below 20, then it is the central hypothyroidism. We should get the cortisol level done and the MRI done in these patients. And if the free T4 is within the normal limit and TSH is below 6, then it is normal. There is no need of any treatment. And if it is more than 10, then treat the patient like a primary hypothyroidism. And if the TSH is between 6 to 10, then look for the risk factors, that is presence of TPO antibody, goiter in the patient, if there is a family history of thyroid disorders in the patient, and if the child is girl. These all are the risk factors that contribute to the treatment part. And if there is no risk factors like TPO negativity, no family history, no goiter, and the patient is boy, then we should follow up these patients. Now, coming to the dose initiation, which is very important. It is in the low 1 to 3 years, like in the very young child, we start with the low dose of we start with a high dose of 4 to 6 microgram per kg per day. Between 3 to 10 years, we start with 3 to 5. And more than 10 years, we further lower the dose of initiation, that is 2 to 4 microgram per kg per day. And in the adult, there is a uniform dose, that is we start with the 1.6 microgram per kg per day, and then we follow up the patient and then titrate accordingly. This we can also use 100 microgram per meter square per day for the calculation of starting dose. And we should start with the lower dose in the patient with subclinical hypothyroidism which present with low FT4, normal FT4 and low FT4 and normal TSH. And in the severe cases, we should also start with the lower doses, because when we start with the high doses, they increase the intracranial pressure and the patient will present with headaches. So we should start with the lower doses in these patients, and always counsel and ask for the patients that always counsel the patient not to take any calcium or iron supplements along with the or just after the or just before the thyroxine medicine, because they will interfere with the absorption of the thyroxine. And also the soy protein, soya beans, soya chunks, they would also interfere with the absorption of the thyroxine. And always counsel the patient that they should not take out the medicine and keep it out of the bottle, because if you have noticed that the bottles are always brown colored glass bottles, or they are plastic bottles, because they are very vulnerable to decomposition after they are exposed to the sunlight. So they should be protected from the sunlight. So coming to the case 6, and I would like Nimisha to go further.
Thank you, ma'am. Starting with the case, 12-year-old girl with obesity, with height of 156 centimeter and weight of 56 kg, with no clinical features suggestive of thyroid disease. With now on diagnosis, there was on screening investigation being done, their TSH was on higher side of 6.4 and was advised treatment. Dr. Balaji sir, how will you like to proceed with this case?
Thank you, Dr. Nimisha. Actually, it's a very practical issue. Everyone knows that hypothyroidism causes weight gain. So most of them order the thyroid function test, and TSH will be elevated mildly, and many have even started thyroxine for that. But we should understand the pathophysiology behind the obesity and TSH relation. Obesity actually increases the leptin, and this leptin has a role in increasing the TRH and TSH because it's an adaptive mechanism where the body, when it becomes obese, tries to reduce down the weight, tries to spend the energy by activating the hypothalamic pituitary axis, and that's why the TSH is getting activated. So here, raised TSH is actually an effect of obesity rather than being the cause. So unless the TSH is more than 10, just mild elevation around say 6.5. So as in this case, we usually should wait and follow up the child unless there are risk factors. So when it is 6 to 10 and there are risk factors like family history is there, girl child, goiter and TPO positive, otherwise we have to follow up. So only when more than 10, we have to treat in an obese child.
So in this child, there was no goiter and free T4 was in the normal range and TPO was negative. So no treatment was required. What will be the key messages you will like to give, sir?
Yeah, so the key messages is that in obesity, the high TSH is actually the effect rather than the cause of the obesity. So don't treat it as a hypothyroidism, and unless it is not more than 10. If it is below 10, no treatment.
Thank you, sir. Moving on to the next case, 10-year-old girl presented with the complaint of poor concentration. Height was 136, weight was 34 kg. The TSH was within normal range and T4 was on the lower side. How will you like to proceed this case, Dr. Rashmi ma'am?
This is a child with poor concentration, so probably she was evaluated for hypothyroidism. Her anthropometry seems to be normal, and she's euthyroid, and TSH is normal, but T4 is slightly low. But here, actually, T4. While assessing T4, we have to consider a few points that it depends upon so many other factors like thyroid levels of thyroid binding, thyroxine binding globulin, albumin, and thyroxine binding prealbumin. So these levels, carrier proteins may be affected in certain illnesses. So T4 may not give the actual picture in the child. So it will be ideal to do a free T4 in this case because that is the one which clearly show or gives clarity whether the child is really hypothyroid or not. And in this case, free T4 was done, which was normal. So no treatment is required, and after ruling out autoimmunity, of course. So if here TPO also was negative, so here no treatment is required.
Key messages you will like to give, ma'am?
Yeah, whenever we are in a dilemma, it's always better to do a free T4 along with TSH. And if there is a borderline decrease in the T4 level, it's always important to do or confirm it with free T4 levels.
Yes, ma'am. The TBG level will be decreased in cases like nephrotic syndrome and liver disease. So we have to confirm it free T4 levels. Moving on to the next case, 12-year-old girl presented with lethargy, height of 140 centimeter, weight of 36 kg, free T4 on the lower side, and TSH was 12. Thyroxine was started on this girl. What will be your plan, Dr. Sonal ma'am?
Yeah. 12-year-old girl, because of the lethargy, she might have been evaluated for the hypothyroidism. Here, the free T4 is low and the TSH is high. So definitely we are justified in starting with a thyroxine treatment. Next, please. Yeah. So like whenever we come across the FT4 low and TSH high, it is definitely the hypothyroidism, but we have to differentiate between primary hypothyroidism and central hypothyroidism, because here in this case, the FT4 is low, but TSH, if it is above 20, then only it will confirm that it is a primary hypothyroidism. And if it is below 20, then it is a central hypothyroidism. But why we need to differentiate between primary and central hypothyroidism is that because central hypothyroidism, many times it is associated with a multiple pituitary hormone deficiency. So child might have deficiency of the cortisol. And so in this condition, if the FT4 is low and TSH is below 20, we must do like cortisol level in the child, and we must do MRI also. And if FT4 is high and if the TSH is undetectable, and then it is thyrotoxicosis, and if it is detectable, then it is TSH adenoma. So we must do when the TSH is less than 20, we must, with a low FT4, we have to screen for the cortisol level. And in this child, it is low cortisol level was there, and their MRI was suggestive of empty cella. Next, please.
So we'll start with hydrocortisone.
Yeah, so we start the thyroxine after the hydrocortisone level, because otherwise it will precipitate the adrenal crisis. So like we have to start hydrocortisone before starting the thyroxine.
The key messages, ma'am?
Yeah. The key messages is there that whenever there is a low free T4 level with TSH less than 20, suspect central hypothyroidism, and always do MRI brain and the cortisol levels, and start thyroxine after if the cortisol is low, start thyroxine after hydrocortisone.
Thank you, ma'am.
Yeah.
Moving on to the next case, 12-year-old girl presented with growth failure. TSH was very high, more than 100, and free T4 level were low. Dr. Rajiv, sir, how will you like to proceed with this case?
So this child is around 10 to 12 years of age with growth failure. So unlikely to be having pubertal changes, but still we need to evaluate them for pubertal changes. And then the basic, after evaluation of the bone age and everything, and we need to exclude that there is celiac disease or other factors which may be responsible for, along with, we'll have to start treatment in this child. The standard dosages for thyroxine supplementation will be 100 microgram per meter square per day. We need to use very good brands in these children. We have to start with small dosages to begin with and gradually build up. There's no urgency of starting full dosage at the day one. At the same time, we need to explain to the parents that they have to store their medication in a proper manner. They should not take it out and keep the medicine outside. The child should not be taking any calcium supplement or any iron supplement along with the thyroxine supplementation when it's done, preferably in the morning. Empty stomach is probably the best way to do it. They should not be soya proteins or soya shakes or whatever they are taking. And then the dosages, because this child is around 9 to 12 years of age, could be around 3 to 5 microgram per kg per day. So that's what the treatment should be. And we need to then follow up on a regular basis, getting the TSH and FT4 levels done.
Thank you, sir. On follow-up after 1 year, TSH was still high and free T4 was also on the higher side. What will be our plan, Dr. Balaji, sir?
Thank you, Dr. Nimisha. Actually, we titrate during the follow-up based on the T4 and TSH. Due to the feedback relationship, whenever TSH is down, T4 will be high, and whenever T4 is low, TSH will be high. So based on that, we decide. So if the free T4 is low and the TSH is high, which means that we have not suppressed, we have not given properly. So we have to increase the dose. And suppose if the TSH is low and the free T4 is high, then maybe we are over treating. We have to reduce the dose. But here it's a dilemma where TSH is also high and free T4 is also high. One important clue is the half-life of the TSH and T4. Free T4 has a very short half-life, whereas TSH has a large half-life of almost weeks. So in order to suppress the TSH, we need to give treatment properly for weeks together. So the compliance has to be daily for weeks together. But for T4, if they have even taken 2 days or 3 days before, the T4 level might come normal. So whenever we have a scenario where T4 looks normal, but TSH is not suppressed, we have to always check the adherence. So adherence is a very important fact. Or sometimes unknowingly they might have even taken the test after taking the thyroid medications immediately. So we should not do the test immediately after taking the thyroxine tablet. So recent intake of medicine is the cause for the raised FT4. Yeah.
So key messages here will be to
Yeah. So I think we have to gradually build in a hypothyroid child, gradually replace that. And timing is important. We should do the test without taking the medications, and always check the adherence when T4 appears high and TSH is also high.
Thank you, sir. So we, if both free T4 and TSH is high, we should check on the adherence of the child. Moving on to the next case, 6-year-old boy with his meningitis was admitted in ICU with the meningitis. Here the TSH was low and the free T4 was also low. So how will you like to approach Dr. Rashmi ma?
Yeah, this is actually a case of meningitis, basically a sick child. So ideally, thyroid profile shouldn't be done in this situation. But if there's a strong suspicion of some underlying hypothyroidism, probably it was done. And here, this as soon as you see this, it appears as though it is central hypothyroidism because both TSH and free T4 are low. So, if we follow this algorithm here, whenever TSH is less than 0.05 milli-international units per liter, it's always good to do a free T4. And if free T4 is found to be high, then it's obvious that it's thyrotoxicosis. And if it is normal, then we have to just follow up. But here the level is in between 0.05 to 0.3, that's 0.1. So here always in a sick child, it's better to do a cortisol level. If the cortisol level is low, then it goes in favor of central hypothyroidism. But in this case, I mean, if it is high, then it is normal. Probably there is no hypothyroidism underlying. It is due to the stress because of the illness. And the cortisol level was done here, which was elevated. So here it's obvious that it's a non-thyroid illness, and the transient depletion of the decrease in the TSH and both free T4 and TSH is basically because of the sickness. So it would be good to follow up this child, repeat the thyroid profile after 2 weeks or when the child becomes all right.
Thank you, ma'am. We'll move to the next part of the topic.
Thank you, Nimisha. So moving forward, so always think thyrotoxicosis when a patient present with weight loss, hypodefecation, that is going to washroom after each and every meal, tremors, weakness, and palpitations, eye signs when they found their eyes have become big. Some patients only present with sudden paralysis, that is periodic paralysis, polyuria. So in these cases, after prescribing the thyroid profile, we should always go for a scan. And remember, if the patient present with goiter or ISAN, and if he or she doesn't present with goiter or ISAN, and if the TSH is low and FT4 is high, then the most common cause is the Graves' disease. Then in these cases, always go for the nuclear, in the cases of Graves' diseases, if we are 100% sure, then the nuclear scan is not compulsory, but where we have a doubt and the patient present with eye signs or goiter, then go for the nuclear scan. And if we see there is an increased uptake, and of the uptake, if we see there is a localized uptake, that is the due to the solitary nodule, and if we see there is a multiple uptakes on the scan, then the diagnosis will be toxic multinodular goiter. And if there is a diffuse uptake, all this isotope is taken by the thyroid gland, then this is the case of Graves' disease. And in cases where there is a decreased uptake and patient present with the pain during swallowing, and if we find there is a tenderness on the examination, then this could be due to the subacute hypothyroiditis. And if there is no pain, no tenderness on the examination, then this could be due to chronic lymphocytic thyroiditis. So moving forward with the next case, a child, day 12 child presents with the irritability.
Thank you, ma'am. So we'll now see the cases of thyrotoxicosis here. The day 12-old child who presented with irritability. Birth weight was 2.8 kg and now on day 12 it was 2.2 kg. Heart rate was on the higher side. There was proptosis. FT4 levels were very high, 44 picomole per liter, and TSH was suppressed, less than 0.001. There was history of Graves' disease in mother who has been treated with radioactive iodine 2 years ago. How will you like to approach this case, Dr. Sonal, ma'am?
Yeah. So this 12-day-old child has presented with irritability, and there is a definite weight loss of 600 grams, which is abnormal. And the child had high heart rate with the proptosis. So this definitely, and FT4 level very high and the TSH low. So this favors thyrotoxicosis. Here, definitely like if and there is a history of mother suffering from the Graves' disease. Now and the treated with a radioactive iodine also. So if the mother is having Graves' disease and is on antithyroid drugs, there are two possibilities which can happen in the child. One thing, it can be because of the transplacental passage of the antithyroid hormones. There will be like child may have hypothyroidism, and there will be transplacental passage of the TRAB antibodies also. And the TRAB antibodies, they have a half-life of 2 weeks. So they may present with that is TRAB antibodies is TSH receptor stimulating antibodies. So this, because they can present initially as hypothyroidism, and after 2 weeks they may present with the thyrotoxicosis also, as it has happened in this child. So but this hyperthyrotoxicosis may be transient, and it may be for up to 6 weeks. But this child needs to be treated with antithyroid drugs and the beta blockers and steroids and iodine if there is a severe symptoms are there. Next.
The key messages.
So yeah, key messages is there whenever there is a tremor and weight loss, as it has occurred in this child, suspect thyrotoxicosis. If there are eye signs, then there are Graves' disease, then it is more likely to be Graves' disease, and treat with the methimazole and the radioactive iodine. Here the catch is that even TRAB antibodies can persist even if the like mother has received radioactive iodine like before in the past. So TRAB antibodies can persist. So even if the patient mother has taken the treatment, the thyrotoxicosis can be there in the baby because of the TRAB antibodies.
Thank you, ma'am. So every child with the history of mother having Graves' disease should be screened at the birth.
Yeah.
Moving on to the next case, a 12-year-old girl with weight loss and tremor with FT4 on the higher side and TSH being suppressed. There was thyroid swelling, but no eye sign, tremors present. What will be the plan in this case, Dr. Rajiv, sir?
We need to see the other clinical features of hyperthyroidism like hyperdefecation or some form of polyuria, or if as you say there is no eye sign. But in this situation, we'll have to then think of hyperthyroidism in this child. And when you think of hyperthyroidism, the first and foremost important test would be a nuclear imaging of this child. So a nuclear scan need to be done, which might show you either an increased uptake or a decreased uptake. In case there is an increased uptake, if it's a solitary nodule or it's a toxic multinodular goiter or it's a Graves' disease, where it will be a diffuse uptake of the technetium of the radionuclide material. But if in that situation, it will be Graves' disease. And in case there is a decreased uptake, could be, yes, it could be subacute or it could be chronic lymphocytic thyroiditis. These all things need treatment in the form of drugs, so which we have already discussed. I think Madam has already discussed that we need to give them methimazole or radioactive iodine.
This child had on screen
and propranolol, yeah, and beta blocker.
So the child was started on treatment with methimazole and beta blocker, and eventually the radioactive iodine treatment can be given if as per the key messages, sir.
So the key message is that we need to be careful whenever a child who presents with us with tremors and weight loss. We have to have a suspicion if even if the eye signs are not there, and if the eye signs are there, it's very well suggested that it's a grave disease, and the treatment is, as we have already discussed, is methimazole and radioactive iodine and beta blockers.
Thank you, sir. Moving on to the next case, 8-year-old boy with a thyroid swelling, as seen in the picture. Dr. Balaji, sir, how will you like to approach this thyroid swelling?
Yeah, so whenever a child presents with a midline swelling so we have to do the routine examination, check whether it is cystic or not, and whether it is moving with the deglutition or not. And when you protrude your tongue, whether it is moving with the tongue movement or not. So here it is a cystic swelling in the midline, and it is moving on protrusion with the tongue. So it's a thyroglossal cyst, so which is actually an embryological structure formed during the thyroid descent from the base of the tongue. So it's a benign thing, and surgery is the clear-cut option. Yeah.
Thank you, sir. So we'll move to the next case. 10-year-old girl with thyroid nodule, as can be seen in this picture. Child on doing the thyroid function test, it was euthyroid, TPO was negative, and child was reassured and sent back to the home. On follow-up, there was rapid growth seen. Dr. Rashmi ma'am, now how will you treat this patient?
Yeah, whenever a child presents with a swelling of the thyroid, we definitely do a thyroid profile. And in this case, it was normal, and hence probably she was reassured. But a few points we have to keep in mind whenever a child presents with thyroid swelling is we have to check the size. If the size is more than 1 centimeter, and if the swelling is fixed to the underlying structures or surrounding structures, and the associated lymph nodes are significantly enlarged, or if there's a history of any long-term low-dose radiation, or there's a family history of some malignancies or these MEN type of syndromes, then we have to consider, we should definitely rule out malignancy in this case. So FNAC or a biopsy is mandatory in this case.
Thank you, ma'am.
Yeah, thank you.
Thanks a lot, Nimisha. And we have developed multiple tools which help in terms of evaluation of thyroid in the form of approach pathways, in form of interpreters, which are available. And they really help us achieve the right diagnosis. If you just enter the thyroid profile, you will get the results, and interpretation will be there. And they have been shown to substantially improve the concordance there. And we have recently launched a thyroid nodule interpreter, which is also looking into those factors as Dr. Rashmi was talking about. If we are able to assess that, that will be something which will get us the right diagnosis from that regards. So we are coming to the end of the thyroid part. We'll see if there are any particular questions which are there. So if we have low TSH suppressed and normal FT4 and normal FT3, is it subclinical hyperthyroidism? Yes, this will be a subclinical thyrotoxicosis. We will not, so this is some scenario in which we have to be careful in terms of evaluation. We don't generally treat a marginally suppressed TSH in that regard, Dr. Asma. Next question from Dr. Asma is TSH resistant. We give TRT with thyroxine and TSH is not suppressed. So TSH resistance. So TSH resistance is a very unusual scenario in which you will have presentation. The TSH will suppress because the resistance is at TSH level. It's not a resistance at the level of FT4. So FT4 will work. So that will be the scenario from that regards. Dr. Mampi Das is asking indication of thyroid ultrasound in congenital hypothyroidism. So it is basically definitely thyroid ultrasound will play a role. It gives us information about the anatomy of the thyroid, and that could really be helpful in that regards. And if thyroid scan is not available, ultrasound will give us a picture as to how things are and how we are going to proceed from that perspective. Dr. Soumya Mohanty is asking about reset mechanism. So reset mechanism of TSH is basically that if the child had been exposed to severe hypothyroidism in birth, the TSH levels will remain very, very high, and they may take much more time. So they will need a much higher level of FT4 to respond. There is a pituitary hyperplasia. So this is what we call as a reset mechanism of the scenario, and this may last. So that is why For the first 1 to 2 years, we should do both FT4 and TSH. Dr. Khadika is asking congenital hypothyroidism, but since age of 1 year, always high TSH around 15 and normal to high FT4. So this we have to think of whether we are dealing with something else. If FT4 is high and TSH is also high, it may be a form of a thyroid hormone resistance. So we have to think of that possibility in that regards. Dr. Munir asking if non-thyroidal illness suspected cortisol is not high, should this exclude NTI? Very, very good point. So if you have a non-thyroidal illness, one of the reasons why your TSH is low is because of high cortisol. So if you have a severe enough stress to cause non-thyroidal illness, cortisol has to be high. So I always use cortisol as a good marker in that regards. Dr. Rajesh TV is asking for breastfeeding, how much time we have to wait after thyroxine. Generally, it's difficult to control in the newborn period, but we say if you have 3 to 4 hours prior to the medicine and maybe half an hour after that, that should be fine. Dr. Dhruv Agarwal is asking 4-day-old newborn with normal TSH but low T4. Should we do FT4 or can we start thyroxine directly? No, this is a very, very scenario in which you have to be very, very cautious. We should do a FT4. If FT4 is low and TSH is normal, we should do a central screen, look for micropenis, midline defect, hypoglycemia, MRI, cortisol, and then start treatment. Dr. Kaushik is asking about when to start treatment for subclinical hypothyroidism. So generally, we do not start routinely unless there is a large goiter, unless there is a TPO antibody which is positive, unless there is a strong family history, and very, very rarely if somebody has had a late effect of cancer therapy. That scenario, we have to start treatment because TSH is a tumorogenic hormone which we want to avoid in that regards. So I think this was a very, very interesting discussion which happened throughout. And I'd like to thank all the participants, Dr. Vibha, Dr. Rashmi, Dr. Balaji, Dr. Sonal, Dr. Rajiv, and Dr. Nimisha for conducting this program wonderfully well in that regard. And this has been a very, very interesting session from that regard. So we'll now be moving towards the next part of pubertal disorders. Dr. Vijay, I think, is not there. So pubertal disorders, so we've discussed about two important parts. We'll now move forward towards the pubertal parts.
Good evening, sir.
So Dr. Vijay, you are there. So
Yes, I am here.
So you would like to share from your side or you would like us to share from here?
You can share, sir. That is not an issue.
Okay, so we'll start off with the session. This is going to be a very, very interesting session in that regards. And we are going to have Dr. Vijay Jaiswal as an expert. And we have got Dr. Yuthika Sharma, who is a well-known pediatric and adolescent gynecologist working at Regency Healthcare, Kanpur. And she's also involved in IVF, infertility, and robotic surgery and minimally invasive surgery. She will be giving very valuable inputs with regards to the pediatric, because there's a lot of overlap between pediatric endocrinology and pediatric gynecology. And unfortunately, there's always a watertight compartment. So it's good to have her inputs in that regards. Dr. Vijay Jaiswal, who is a well-known pediatric endocrinologist from Meerut, and he is the ex-professor and head of Department of Pediatrics at LLRM Meerut, and now working extensively in terms of pediatric endocrine care. We've got Dr. Arpita Bhagwanshi, who is Professor, Department of Pediatrics, King George Medical University, Lucknow, and she has been closely involved with Mediclasses in Grow India to work in terms of pediatric endocrinology. Dr. Ayesha Ahmed, who is a professor of pediatrics at JLN Medical College, Aligarh. And we have got Dr. Padma Priya, who is assistant professor, Department of Pediatrics from Trichy. So over to you, Dr. Vijay.
Thank you, sir. So we are going to have a very important session that is on puberty. We are going to discuss pubertal disorders in boys and girls. So coming to this picture and how we are going to present that this girl was presented with early breast development. So we have to see whether this is a common scenario, how it is going to happen. So this can be 90% physiological, and there can be some in about 10% disorders. So we have to evaluate. Then next slide, please. So precocious puberty in girls, when to suspect that if there is pubic hair or enlargement in the breast, that is thelarchy, before 8 years. That is very important. That age limit before 8 years, it is going to be precocious, or vaginal bleeding before 9.5 years. So this is going to be a precocious puberty in girls. Next slide, please. So what are the puberty mimickers? That they are not actually the precocious puberty. So there can be neonatal thelarchy, lipomastia, that breast is looking enlarged, but actually that is pad of fat. This is lipid stored. So this is lipomastia, actual fibroglandular tissue. And pubic hair of infancy can be a normal presenter or mimickers. So actually they are not signs of puberty. So if we are going to encounter a girl with precocious puberty, this is a very simple and important algorithm that how the precocious puberty in girl we are going to see. We have to see whether this is in isolation or there are some component, either isolated breast enlargement or isolated pubic hair or just menarche, or there can be complete, that is all the consonants, that is thelarche, pubarche and menarche can be there. If there is complete, then we have to see whether that is central or peripheral precocious puberty. So in case of central, which is going to be idiopathic in 80 to 90% of cases, and about 10% cases it is going to be organic. But again there is a rider regarding this, that at what age of the child is going to present. So particularly in less than 6 years, a girl presented with menarche, probably it is going to be an organic cause. So it is going to depend. So what organic causes actually we have to deal, that we have to see for CNS lesion. So hematoma, glioma, hydrocephalus, arachnoid cyst. So they can trigger the thing, and there can be central precocious puberty. Otherwise, there can be genetic mutation, KIS receptor mutation, MKRN3 gene mutation can be there. Or there can be insult in the milieu of the CNS, like radiation or say CNS infection, particularly tuberculosis or say hydrocephalus, which can be a common condition and may lead to development of precocious puberty in girls. Now coming to the, we have discussed the central precocious puberty, where all the things, all the three components, that is thelarche, pubarche, menarche, all the things are going to be there. Now coming to the peripheral precocious puberty, that is organ specific, there is overproduction can be there. So McCune-Albright syndrome can be there, which can present very early along with other features. There can be hypothyroidism, there can be cyst formation, there can be tumor, or there can be adrenal tumor, or there can be excess of the hormones, that is aromatose or exogenous or Pew-Jagger syndrome can be there. So in nutshell, that how we are going to deal with the precocious puberty again before 8 years. So either pubic hair in etiology, adrenarche, there can be local causes, hypothyroidism, and in consonant, that is organic causes, central precocious puberty can be there. Next, please.
I think Dr. Vijay is having a bit of a connection issue. So essentially, when you're looking at hormonal production,
active LH hormone is more important than immunoreactive. So we are going to see the main. So before this grade 2, it is, that is in pre-pubertal state, it is going to be, LH is going to be less than 0.1. Next, please. Yes. So if we are going to, we are concerned that we want to confirm that GnRH agonist stimulation test is important. If the girl child is less than 3 years, the stimulated is going to be 9. So beyond 9 has to be taken as a sign of precocious puberty. Or if beyond 3 years, then 5 is the cutoff for. And important thing is that these to be done if this is 0.2. That is, there is no need in all girl to confirm with GnRH analog if basal LH is quite high. Next, please. Yes, next slide. Yes. So we have to see again that apart from hormonal changes, what are the biophysical, that is anatomical changes. So prepubertal uterus is quite tubular in shape, and shape is very important and sensitive parameter to diagnose the precocity or whether the patient is entering in puberty. So if you are going to see the prepubertal uterus, here you can see the tubular structure, that is AP diameter is about 1:1. Here you can see the globular, that is fundus is being formed, and it is going to have globular shape structure, and it is as sensitive as the LH hormonal level. And you can see here. So what are the parameters? Next slide. So what are the numbers that beyond 32? Yes. So less than 32 millimeter is prepubertal, more than 32 millimeter is pubertal. And coming to the ovarian volume, so beyond 2 ml will be taken as a commencement of the puberty. Yes, please. Next. Yes. So how we are going to approach that? We have to see what is the extent of the puberty, whether this is in isolation, that is pubarchy. We have to see the DHEAS, whether this is in level of less than 40, 40 to 135 or beyond 135. So if this is less than 40, this is isolated pubarchy. 40 to 135, that is adrenarchy. Beyond 135, we have to see, we have to rule out the congenital adrenal hyperplasia, and we have to see the 17 OSP. Along with that, if needed, imaging is required. Then we have to see what is the level of 17 OSP. This is unstimulated, that is without synectine test. If it is less than 1.5 nanogram per ml, imaging to be done. If it is 1.7 to 15 nanogram per ml, ACTS, that is synectine test, can be done. And if it is beyond 15 nanogram per ml, it is 21 hydroxylase deficiency, that is the commonest variety of CH. Now coming to the second, that is isolated vaginal bleeding without any thelarchy or pubarchy, you have to rule out the local cause. So because that is not going to happen. Now coming to the third part, that is whether complete precocious puberty, we have to take the account of bone age. Now, if bone age is retarded and there are signs of precocious puberty, there is just single condition where signs of precocity are there and bone age is retarded. It has to be hypothyroid. So you have to be cautious that you have to take the thyroid function. If bone age is normal, that can be taken as a slowly progressive puberty. So that to be not labeled as precocious puberty, slowly progressive variation. But yes, it is mandatory to do the regular follow-up for further changes. And if the bone age is advanced with sign and symptoms of precocious puberty, then LH is going to be deciding factor. So what is if LH is in the level of pubertal level, that is it is going to be central precocious puberty. And I have already told you that if precocity in girl less than 6 years, it has precocity, organic causes can be there. So MRI is really required in these cases. Now, if LH is low or pre-pubertal, we have to see the peripheral precocious puberty.
Thanks.
So this was in nutshell that how we are going to approach precocious puberty in girl child. So now we are going to discuss the cases among our panelists, please.
Thanks a lot, Dr. Vijay. I'll now invite Dr. Ria to carry forward with regards to the cases, please.
Yes, sir.
Thank you, sir.
Yes.
Good evening, everyone. Starting with the case number 1, a 7-year-old girl child presented with thelarchy. On examination, she was B2, M0, pubic hair 1, and height was 118 centimeter. Bone age was done, and it was 6.5 years. LH was 0.1, FSH was 2.2, and E2 was less than 10. So I would like to ask Dr. Aisha ma'am to tell the approach of this case.
Okay, thank you, Dr. Ria. So can we go back to the slide? So here we have a 7-year-old girl who presents with thelarchy. So see, this is the borderline age where the girl can have precocious puberty or even normal onset of puberty. So as it was said that presence of breast enlargement heralds the onset of puberty. So this could be a normal sign. So you have to see the girl, the child in toto and just not decide for investigation based on a single presence of a thelarchy. So as we can see here, other parameters like height is normal and pubic hair, there is no evidence of adrenarchy. and she was subjected to a bone age which was within normal range. And also the biochemical investigations were done, which were absolutely normal. So before going for abnormal, always think about normal thing first. So could this be a normal girl landing up into puberty, having breast enlargement as a first sign of puberty? Or else this could be something like we have to look for, if you remember, puberty mimics, which were discussed by Dr. Vijay. So maybe you have to look for BMI and other associated features in the child. So can we go to the flow chart, please? So depending upon, you have to look where is the onset of puberty and what are other features and other pointers of a pubertal onset in the child. How is it progressing? And other mimics also. This could be a normal finding also. So before going for abnormal, always think about normal. That's the take home. So this was actually a case of lipomastria. So she had fat deposition. She had perhaps BMI on the higher side, and that was not a case of precocious puberty, but absolutely normal girl. And the vaginal mucosa red, which also indicates prepubertal changes. So reassurance is all that is required in such a girl, and you need not go for further investigations. So the key messages in such a situation would be always think about normal things first. So confirm puberty before workup, because this could be normal. You have to look at the age, as I said, presence of associated features, and also the progression of the pubertal features. And lipomastria is a very common mimic. So this could be a normal puberty, or even if the child has abnormal fat deposition, it could be a lipomastria. So not every child having one onset, one sign of puberty needs not undergo all sorts of investigations.
Thank you, ma'am. Coming to the case number 2, a 2-year-old girl child presented with Thilaki. Onset started 6 months ago. It was slowly progressive, and on examination, it was B3, PH1, and M0. I would like to ask Dr. Arpita ma'am to give her input.
Thank you, doctor. So if we see this girl very closely, it is clearly a case of precocious puberty. But once we see the extent of puberty, we can see that it is isolated thelarchy and has been progressing for quite some time, and still the breast stage is 3 in this child. But again, it may be an initial manifestation of rapidly progressing puberty. So we should do a thorough clinical examination of this child in terms of neurological features. If she has any headache or gelastic seizures, we should do a general examination to look for any cafe au lait spot and look at the height of the child. So in terms of that, can you tell me what we found on examination?
On examination, the height was 88 centimeter and there were no cafe au lait spots.
Okay, so she seems to be a slowly progressing isolated thelarchy child, but we need to do a thorough examination in terms of bone age. We need to do a gonadotrophin levels and also USG pelvis to look at the uterine size, the endometrial thickness.
So on investigations, it was found that LH was less than 0.1, FSH was 3.2, and E2 was 8 picomole per liter.
So the gonadotrophin levels were less. And what about the USG pelvis?
USG showed small cyst in the ovaries.
Okay, so it is likely to be a case of isolated, slowly progressing thelarchy, and it does not need any management as such, and just reassurance on our part as a physician. And but still, we need to closely follow this child for any signs of any rapidly progressive precocious puberty. So the key messages coming out of this child is that isolated thelarchy is quite common between 1 to 3 years in girls, and in between 6 to 8 years. But we need to closely follow these children for also rapidly progressing symptoms. And the FSH may be slightly elevated in these children, which may lead to microcyst, which were there in our child.
Thank you, ma'am. Coming to case number 3, 6-year-old girl child presented with Thilaki. Thilaki was there from last 1 month. Height was 124 centimeter. On examination, pH 2, B3, and vaginal mucosa was pink. In growth chart, we can see that the height and weight is okay. So I would like to ask Dr. Pannapriya to how to approach this case.
Yeah, good evening. Unlike other two cases, the first case is lipomestia, which is breast 2, but here breast 3 is really significant. So we have to look out for the actual cause of thelarchy. And the onset of thelarchy is just 1 month and there is progressive development. And here, before jumping into extensive investigation, it is always better to look into the bone age. So always concentrate on bone age. Look whether the bone age is advanced here or not. So the child is 6 years, but the bone age is 11 years, which arouses a strong possibility of precocious puberty. Then what we have to do is we have to see basal LH and then stimulated LH. See whether if it is elevated or not. If it is elevated, then think of central precocious puberty. If it is not elevated, think of peripheral precocious puberty. And here, what is essential is if it is advanced, we have to start the child on GnRH analog as a treatment. So the key message here, what I wanted to insist is before entering into extensive investigations, always give importance for bone age assessment. If the bone age is advanced, look for precocious puberty.
Okay, thank you, ma'am. Coming to case number 4, 7-year-old girl child presented with isolated vaginal bleeding. There was only one episode. On examination, she was B1, PH1, and M0. Vagina mucosa was red. So I would like to ask Dr. Yuthika ma'am to give her input in this case.
Thank you, doctor. Basically, unlike the last 3 cases where you had some signs of estrogenization along with the symptoms of precocious puberty, here we cannot see anything. So there is no breast development, there is no pubarchy, and there is no, on examination, the vaginal mucosa is red, which is a sign of not being exposed to estrogen. So whenever you have got a case like this, you have to think of not endocrinology, but something gynecological. And if a young girl is presenting with isolated bleeding, vaginal bleeding, it's probably a local cause, and it could be anything from trauma to infections, vulvovaginitis. Sometimes a foreign body lodges there, and it can be also a sinister sign of sexual abuse. So it needs to be really worked up thoroughly. If you have got a patient with isolated vaginal bleeding, young, and I would not want to do any kinds of hormonal investigations when there are no signs of basically estrogenization. So if you've got no breasts, no pubic hairs, and only isolated bleeding, but you would probably need to examine her properly locally, maybe through an examination under anesthesia and doing a vaginoscopy. So whether it was done for this girl and what was found, so a foreign body was found. So always keep in mind, so if you go for key messages in these cases, we've got, if there is no breast development, no signs of estrogenization, and isolated bleeding, a gynecological workup is very much essential. Thank you.
Thank you, ma'am. Case number 5, a 7-year-old girl child presented with thelarchy and menarche. Thelarchy was from last 3 months. Height was 100 centimeter. On ultrasound, it showed a cyst. In growth chart, it shows the height less than -3 standard deviation, centile. And on examination, she was PH1, B3, and vagina mucosa was pink. I would like to ask Dr. Aisha ma'am to tell us the approach. Dr. Aisha ma'am.
I'm sorry about that. Okay, so here we have again a 7-year-old girl. Here, along with the development of breast, that is thelarchy, she also has onset of menses. And also, as I said, you have to see the child in toto. So, like for normally in precocious puberty, it's not only the onset, like increase in the reproductive organs and increase in thelarchy and adrenarche, but also there is increase in the statural growth. Okay, so you have to look for both height and also the bone age in all the cases. So as you can see here, this girl has both this weight is. Can we go back to the previous slide, please? So the point here, important pointer here is, or you can see, you can say clue in the history and examination is that her height is very short as compared to her age. and breast mucosa, the breast is stage 3, and the uterine mucosa is pink, which indicates again she has been exposed to estrogen. So definitely there is something organic, something in the child which needs further evaluation. So again, going for that, so complete thilarchy. So again, you have to go for bone age. That is the next step while evaluating any girl with precocious puberty, and you have to look for other signs also.
Bone
So
age.
bone age was done as the next step, and which was low as compared to her chronological age. Again, this is something very significant because normally in precocious puberty you have bone age which is advanced because the child is having onset of puberty. But here there are few exceptions, like the catch here is bone age is retarded. So definitely if you go to the flow chart, so retarded, the differentials are very few for such a condition. And thyroid disorders, hypothyroidism is the most common condition in such a scenario. So TSH was done, which was more than 100. So this was a case of hypothyroidism, which presented with precocious puberty. So the key messages with here would be that any child with precocious puberty, always look at the oxological parameters also. And if there is any like short stature, you should also always think about hypothyroidism as the etiology. And the ovarian cyst here is again a sort of reaction to the increased TSH. So increased TSH has analogy to the FSH receptors, which leads to formation of ovarian cyst. So you should always, so this is an effect of uncontrolled prolonged hypothyroidism. So this girl needs to undergo treatment for hypothyroidism, which will take care of its evolving precocity.
Thank you, ma'am.
So thank you so much.
Coming to case number 6, 1.5-year-old girl presented with menarche. On examination, she was breast 2 and pH 1. Height was 86 centimeter, which was plus 1 standard deviation. I would like to ask Dr. Arpita ma'am to approach this case.
Yeah, thank you. So this is a very, very young girl of 1.5-year age, and it is a clear-cut case of complete precocious puberty with B2 pubic hair stage 1, and the child has entered into menarche, and she's quite tall for her age. So we should be carefully looking and evaluating this child very in an emergency basis. We have to look for neurological signs in terms of your headache and elastic seizures, and also the bone age, as well as the pooled LH in this child.
LH was 5.6, FSH was 1.8, and E2 was very high, 46 pico.
So the LH was very high, pointing towards a central precocious puberty etiology. So this child needs an urgent MRI brain to look at what is going wrong with this child.
MRI head was done.
Okay, so it reveals a hypothalamic hematoma. So it is a benign lesion. It does not need any neurosurgical intervention and just needs a GnRH analog at a monthly or 3-monthly interval. And the symptoms are controlled on that. So we can just advise the girl on GnRH therapy and monitor closely. So the key messages coming out of this child is that high LH more than 0.3 in less than 3-year-old child is pointed towards a central precocious puberty. And children with precocious puberty, especially the girls before 6 years of age, needs universal and MRI brain to look for the etiology.
Thank you, ma'am. Coming to case number 7, 1-year-old girl child presented with thilarchy of 3-month duration. Her height was 88 centimeter, weight was 12 kg. On examination, she was pH 1, B3, and vaginal mucosa was red. On investigation, LH was less than 0.1, FSH was less than 0.1, and E2 was 10 picogram per liter. I would like to ask Dr. Yutika ma'am to approach this case.
Thank you, doctor. Now, this is a really young girl presenting with an advanced breast development of breast stage 3, while all the other parameters like LH, FSH, and estradiol, even the estrogen effect is not present. So some sort of a transient estrogenization this girl has had, and especially this is not central, as Dr. Arpita has already said, that the LH is quite low. So we need to really investigate her where the estrogen is coming. So obviously, so on examination, we can see that there are some labial adhesions, and usually labial adhesions are quite basically um, uh, trauma producing to the parents, although they are benign. But parents generally go from one doctor to the other for getting these labial adhesions treated. Usually they occur due to deficiency of estrogen, which occurs around this age group in 1 to 2-year-old girl, where the estrogen effect of intrauterine estrogen effect is now going, and the vulval epithelium becomes really thin and it becomes fused. Usually benign. If you follow up these girls, labial adhesions usually go away on their own. But sometimes if the girls are symptomatic, or sometimes if the parents are very pestering, doctors resort to use topical estrogen to heal these lesions, which can lead to peripheral precocious puberty. So an exogenous estrogen can lead to development of thelarchy, and that's why such treatments need to be avoided, because eventually it can cause a lot of problems to the girl. So the key messages in these cases have got a transient estrogenization with a low LHF such an estradiol. Definitely, it could be an exogenous, and especially in this age group, inquire further whether the girl is being given any sort of estrogen treatment, maybe topical or oral, and has to be stopped.
Thank you, ma'am.
Thank you.
Dr. Vijay,
So we have finished the precocious puberty in girl children. Now it's time for boys. And we can see that there are two more most important differences, that contrary to the precocious puberty in girls, where most of the things were idiopathic. Here, if the child if is going to have the male child having precocious puberty and of central variety, then probably this can be organic. So chances of organic is more. So we have to see that how we're going to learn. Previous slide, please. Yes. So any development that is pubic hair, yes. So how it is going to be? So what is the pivotal progression that we have to see? Not the penile length, but rather the testicular volume first. So testicular volume is going to be enlarged, and what is the magical value? That is T4. That is 4 ml of testicular volume is going to be depictive of the brink of puberty. That is commencement of puberty. Then it is going to be penile growth, that is increase in the penile length, and then penile thickness, that girth is going to be increasing, and glans formation is going to be there. And finally the final part is that adult growth. So I have already discussed that T4 is the where like thelarchy, that is T4 volume is the harbinger, that is it is going to say that yes, the child has now entered into puberty. Second, that we have to remember two critical testicular volume. One is T4 and another is T10. So T10, what it is going to do, that it is telling you that the child is going to have growth spurt in this period. So by T10, the child is going to have growth spurt. And then the last is spermarchy, that is sperm is going to be formed. So yes, we have already discussed that pubertal 4 ml and T10 is the sign for growth spurt. Next, please. So when to say precocious puberty, contrary to the girls, where if there is development of breast or say signs of puberty before 8, in girls that they were taken as a precocious puberty, but in boys before 9 is the sign for to look for precocious puberty. So it can present like isolated puberty. So what can be the etiology if we are going to see? So precocious puberty can be central. Yes, here idiopathic about 30% and organic. So chances of organic are more in cases of male. So it is going to be say if it is central, CNS lesion can be hematoma, which is non-surgical evaluation, glioma, hydrocephalus, organic cyst. So any LEU, if CNS LEU is going to be disturbed, there can be trigger in terms of central precocious puberty. There can be genetic causes, that is KIS1 receptor, or say familial tendency MKRN3 receptor. And the third, that is CNS insult, can be in terms of CNS radiation or say whole body radiation, or say CNS infection, that is encephalitis, meningitis, long-term hydrocephalus, can produce central precocious puberty in male children. Now coming to the peripheral precocious puberty. So here central and peripheral both are 50-50%. The commonest cause of peripheral precocious puberty in boys is adrenal, which is 21 hydroxylase deficiency is the commonest. And if there is signs of precocious puberty in boy with hypertension, probability of 11 hydroxylase deficiency of variant of CAS can be there, or there can be carcinoma. And coming to the testicular, that is testicular tumor, SCD tumor and testotoxicosis. Now we have to see that what is the consonant, that what is the depiction of testicular volume. Yes. So testicular volume in case of central precocious puberty, obviously it is going to be globular and say in puberty, that is beyond 4 ml. So testicular volume has to be enlarged or in pubertal range if the child is having central precocious puberty. Now coming to the peripheral precocious puberty, they are going to be short or not in between, that the size is midway. So there can be, that can be presentation of HCG dependent tumor. And if there is asymmetry in the volume of testes, then probably we are going to deal with testicular tumor and we have to act or investigate accordingly. Next, please. Yes. So how we are going to approach the cases of precocious puberty in male, that is we have to see the LH is the most important hormone to look for. Basal LH is more than 0.2, so there is no need to do this GNRH stimulation test, and MRI head should be done, and depending upon the condition, these children to be treated with GNRH analog therapy. Now if there is borderline, that is LH is between 0.1 to 0.2 and the child is having signs of precocious puberty, then it is always prudent to have GNRH stimulation test, and we have to see the figure of LH, that is it is beyond 5 or less than 5. So if it is beyond 5, it means that this is central precocious puberty and we have to do the MRI on that child. So here in boys, if your stimulated LH is beyond 5, it is mandatory to do MRI. And if it is LH is less than 5, that is peripheral precocious puberty after GNR stimulation, or say less than 0.1 unstimulated, then we have to look for adrenal mass. If there is adrenal mass, then there can be high chances of adrenal carcinoma. If there is no adrenal mass detected, then we have to go for 17 hydroxyprogesterone level. If this is high, then we have to investigate and treat like CH. If this is normal, then we have to see that HCG. If it is high, that is HCG tumor, and we have to localize the lesion, whether CT, abdomen or chest. If it is normal, then probably it is receptor defect or say genetic study is required in this case.
Thank you, sir. Starting with the cases.
Yes.
Case number 8, 4-year-old boy came with the signs of early puberty. So I'd like to ask Dr. Padmapriya ma'am to approach this case.
Yeah, thank you. As it was well explained by Dr. Vijay sir, this child 4-year-old, but the testicular volume is increased for 4-year-old child, that is around more than 4 ml. So here what we want to think is, since the testis is increased on both the sides, it is more towards central precocious puberty. As it is well explained, if it is small, you have to think of peripheral precocious puberty, and if the size is in between, HCG dependent, and if it is unilaterally enlarged, again it is testicular tumor. But in the child, it was bilaterally enlarged testis, so we are thinking more towards central precocious puberty. Then we have to do LH level as explained, and if it is more than 2, always rule out central cause. So we have to subject the child for MRI head. So here the LH is elevated, that is 2.2, and we have to subject the child for MRI head to see any lesion in the head. So as it is explained in the child who had precocious puberty in female, again this child also have a hematoma which is important cause of precocious puberty, where it is a normal tissue in an abnormal plane. Again, as Madam Arpita told, we have to treat these children with GnRH analog.
What would be the key message, ma'am?
So key message, always whenever you suspect any child with increased testicular volume, both the sides, always think of central precocious puberty. And in any child you suspecting central precocious puberty, always proceed with MRI head.
Thank you, ma'am. Coming to case number 9, a 7-year-old boy came with the signs of early puberty. I would like Dr. Aisha, ma'am, to look at this case.
Okay, thank you. So I'm back again. So here again, we see a child who is 7-year-old boy who presents with early puberty. So I look at the child. Looks like he has development of organs, but something does not fit right. So this case is somewhat different from the earlier one that we had discussed. Like that child had onset testicular volume had increased. So always remember, in true puberty, it's always the testicular volume which starts first, followed by penile growth. So here you can see that testes look very small as compared to the penile size. So something does not sit right. This does not appear to be a true cause of puberty. So you have to evaluate further. So again, you have to go for biochemical parameters LH and FSH to look for puberty. So as you can see, LH and FSH are suppressed, normal for his age, but the testosterone levels are very high. So this is not a typical case of simple puberty. So you have to look for. So as I said, there is discrepancy. So you have to look for, because LH is suppressed. So you have to look for peripheral causes of puberty, like discussed for girls. So that was very. So the LH levels were very low, unstimulated. So you have to look for peripheral causes. Adrenal causes are the most common cause in this age group. So you have to look for adrenal mass. If it's there, then you have to think about carcinoma. If not there, then you have to think for another cause, that is congenital adrenal hyperplasia. So you have to subject the child to further biochemical investigations. So 7 OHP levels were high. So this child was a case of congenital adrenal hyperplasia, and 21 hydroxylase deficiency being the most common cause. So here we are dealing with a child who presents with precocious puberty because of underlying CAH, which was not diagnosed till 7 years of age. The key messages here would be, so in case of small testicular volume, because in central puberty, you have to see for the order. So testicular, whenever there is discrepancy between the testicular volume and penile length, so look for peripheral causes. And 17 OHP is a very important parameter to look for in such children. Okay, thank you.
Thank you so much, ma'am. I would like to hand over to Dr. Vijay, sir, for the further delayed puberty.
Thank you. So we have discussed now, that is precocious puberty in girls, and then precocious puberty in boys. Now it's time to, if something wrong, that the things, the body changes are not happening, that this is a case of delayed puberty, and how intensively we have to investigate. So it is a common problem, and mostly in 1/3 it is going to be physiological, and there can be so physical, but 1/3 pathological. So it's quite common, and this is disorders can be there. So cautious and timely assessment is really important to understand that how we are going to approach. Because if you have not diagnosed in time, that can be catastrophe. And if you are intensively investigating a very functional cause, then it is also going to have resource. So we have to see that what is the delayed puberty in girls, when to think. That is no thelarchy by 13 years. That is no breast development by 13 years, management of thelarchy. So this time period is really very important to understand. Yes, please. Yes, next. Yes, so if how we are going to deal with delayed puberty in girls. So this is the thing, that delayed puberty physiological, which is going to be 30% self-limited, but yes, follow-up is really required. If it is pathological, we have to see whether this is, there can be two variety, that is hypogonadotropic hypothyroidism. It means that central, there is something deficiency at level of hypothalamus or pituitary, and the second can be hypergonadotropic, that is terminal organ, that is ovarian failure or something like that. So if we are going to think about hypogonadotropic hypogonadism, there can be functional, that is not always organic. There can be functional, which can be nutrition, say in anorexia nervosa, or say any chronic systemic illness, or say hyperprolactinoma. There can be this type of presentation, that is hypogonadotropic hypogonadism. But in permanent variety, what is going to happen, that this can be multiple pituitary hormone deficiency, and you have to evaluate your patient very thoroughly. And the first step is that good history, good examination, see whether there can be any midline defects are there or not, genetic history, insult, infection, we have to see. And then it can be in isolation, that is either multiple pituitary hormone deficiency, so all the hormones are going to be low, or say isolated. So there can be KIS1 receptor deficit, GnRH, or say FGFR or CAL. One more thing is important, that we don't have to mislead by the history of smell, that is anosmia or hyposmia. There can be about 50% of the variant of hypogonadotropic hypogonadism, which are going to have normo-osmic hypogonadotropic hypogonadism. So yes, there can be, this can be a tricky situation. Now we have to approach that what is the status of puberty, that is pubic hair. So it has to be, so if there is delayed signs of delayed puberty along with presence of pubic hair, it has to be something problem. It's not going to be like CDGP or something like that. So it's really important. With the puberty, yes. So pubic hair and etiology. So there can be GnRH deficiency, CDGP or illness, androgen insensitivity syndrome, and there can be real malformation, that is CNS malformation, which can have multiple pituitary hormone deficiency. Next, please. Yes. So how we are going to approach, that is screening test. So depending upon the gonadotropin level, whether this is high or low. So high, that is karyotype genetics are really required. Sorry. Yes. And if this is low, then whether there are pointers of hypogonadotropic hypogonadism, which may not be necessary always. But yes, we have to see, that is whether anosmia or hyposmia, synkinesia, or say CNS features are there. If they are there, yes, then it is hypogonadotropic hypogonadism are not there, then GnRH agonist stimulation test to be done, and then we have to see the level of LH. Mind you, this is the LH which is going to be deciding factor. If LH after stimulation is less than 5, it is going to be permanent variety of hypogonadotropic hypogonadism. If LH is above 5 milliunit per liter, this is assuring, and you can assure the parents that we will see further, and it is going to be probably constitutional delay of growth and puberty. Next, please.
Importantly, as Dr. Vijay talked about, we have to look at the screening investigations followed by gonadotropins, and if needed, a GnRH stimulation. Most girls will have some pathology, 30% will have CDGP. So over to Dr. Riya.
Coming to the cases, case number 10, a 13-year-old girl came with the concern of delayed puberty. She was on breast stage 1, pubic hair 1, height was 145 centimeter and weight was 40 kg. LH was 0.1 unit per liter and FSH was 0.1. When ultrasound was done, it showed absent uterus. So I would like to ask Dr. Yuthika ma'am to give her input.
Now, this is basically a case of a girl where the puberty has not started, and clearly her LH and FSH levels are still very low. So whenever you don't have the estrogen available, the breast will not develop. Similarly, the uterus is also difficult to locate because the prepubertal uterus is quite paper thin and tubular. And if, especially if the girl is obese, and if the doctors are not very well trained enough, or the bladder is not very well full, very commonly they can actually miss a prepubertal uterus. So a very devastating statement to make that the uterus is absent. It sort of completely gets brings the parents to a frenzy. So what I already always say, if there are no breasts, please don't get any ultrasound done. Work up for delayed puberty, and ultrasound should be done only when estrogenization, or should be done only by a very trained person to say that the uterus is absent. In this particular, when properly it was done, it was a small uterus, and clearly this girl was by definition also not delayed puberty. It was an unnecessary and early workup done for this girl. She could have been just reassured and observed for development of signs of puberty.
What would be the key messages, ma'am?
So the key messages would be uterus is a prepubertal uterus is quite difficult to locate. Only with untrained and a good ultrasound machine, they will be located, and therefore it's very important to not to do uterine, assessment before puberty starts in. Or so if there is no breast, please don't look for any uterus. A careful follow-up in this girl is essential because even though she has presented a bit early, she could still be delayed puberty. So look for signs, explain the family that puberty can come up a little late in these girls, and just to keep her in follow. That's what we want.
Yes, thank you, ma'am. Case number 10, a 16-year-old girl child presented with delayed puberty. She was on breast stage 1, pubic hair 1, height was 135 centimeter and weight was 28 kg. On investigations, we found LH was 0.2 and FSH was 1.1. And she was advised to get estradiol levels checked. So I would like to ask Dr. Arpita ma'am to approach this case.
So if we look at the girl, so this girl is clearly a case of delayed puberty as per definition. But if we look at the weight and the height, she also has growth failure along with delayed puberty. And as Vijay sir was mentioning, before evaluating a child with delayed puberty, we have to rule out chronic systemic illnesses, and nothing can bypass a careful history and examination. In this girl, we could have done tests to exclude those chronic illnesses in terms of celiac disease, anemia, liver function test, thyroid function test. These should be done, and a careful history in terms of frequent history of diarrhea, vomiting, or any abdominal symptoms, or coexistent anemia, blood transfusion history should have been taken before jumping to the endocrinal workup. So, was this child further evaluated?
Yes,
So this
ma'am.
girl had anemia and had clubbing and a very high TTG. So she was a case of celiac disease, and that's why she was not going into puberty. So the key messages I would like to highlight from this patient is that we have to rule out chronic systemic illnesses before jumping onto the endocrinal workup, because even in those systemic illnesses, there will be low LH, therefore confusing us further. So we need to carefully exclude those and then do the further endocrinal workup. And any child coming to us with short stature, anemia, clubbing, these are pointers celiac disease, and celiac should be evaluated in all the girls with short stature and delayed puberty. Thank you.
Thank you, ma'am. Coming to the next case, a 12-year-old girl child presented with growth failure. Her height was 122 centimeter, weight was 27 kg. On examination, she was B1, PH1, and M0. She had brachymetacarpia and webbing. FSH was done, which was high, it was 88, and she was advised to get growth hormone levels done. She had abdominal lump And on karyotyping, she was 46X6 and 45XO mosaic pattern. So I would like to ask Dr. Padmapriya ma'am to approach this case.
Yeah, thank you. It was already insisted about the importance of ruling out chronic systemic illnesses. Now, here, this is a 12-year-old child with growth failure, and child had a delayed puberty. So, any child, especially female child with growth failure, it is always important to do a karyotyping. Here, the child also had a features of brachy, metacarpia, and webbing, which is very classical of Turner. And as we have done FSH and it's highly elevated, again it is hypergonadotropic hypogonadism. Never miss a Y cell line in these children because that might be a cause for gonadoblastoma, which is the reason for the child having abdominal lump here. So always remember doing a karyotyping in any child with growth failure, and especially being a female, better do a karyotyping, which is very, very important. And here we can treat this child with growth hormone therapy to give a proper growth, and gradual induction is the mode of treatment. And to remove the abdominal lump is also an important key message here.
Thank you, ma'am. Coming to case number 13, a 16-year-old girl child presented with primary amenorrhea. On examination, she was B4, PH1 and M0. Height was 163 centimeter, weight was 52 kg, and FSH was high at 88, and LH was 45, and E2 was very low, less than 5. There was no hirsutism. I would like to ask Dr. Aisha ma'am to approach this case.
So again, by definition, this is a 16-year-old girl. So definitely she has not had onset. She has not has onset of menarche as such. But the breast development is 4. But again, you see there is no onset of pubarche also. So there is discrepancy. She has breast development, but no development of hair. Height and weight parameters are within normal range. And on the, going for again gonadotropin levels, as you can see, FSH and LH are very high. So you have to look for peripheral causes, problem somewhere in the periphery. So, okay. So if you remember, like you have to go for LH and FSH. If the levels are very high, that indicates hypergonadotropic hypogonadism. That means problem is at the periphery. Whereas in levels where LH and FSH are not raised, so you have to look for systemic causes. So pubarche is a vital cue here. Like you have a development of breast, which is fully developed breast, but there is no evidence of pubarche. So some problem with the androgen levels. So that strongly suggests AIS, that is androgen insensitivity syndrome. So that will be the thing that you have to look for, both the parameters, if there is no pubertal onset after a certain age.
Thank you, ma'am. Case number 14, a 14-year-old girl child presented with hirsutism. She had menarche 1 year ago. Periods came every 2 months. The FGS scoring was 6, and ultrasound showed PCO appearance. So this was the ultrasound finding, which showed PCOD appearance. So I would like to ask Dr. Yuthika ma'am to give us some insight. Dr. Yuthika ma'am.
Ma'am, I think
Okay,
you.
sorry.
So this is
Thanks a lot. Dr. Ria, can you hear me?
Yes, ma'am.
Hello? Can you hear me?
Yes,
Yes.
ma'am.
Yes, we can.
Okay. So in this young girl, 14-year-old, with menarche only a year back, having cycles that, having periods every 2 months, with mild hirsutism and an ultrasound appearance of polycystic ovarian morphology, very commonly is being overdiagnosed as polycystic ovarian disease. But within first 2 years, and in some girls, within the first 5 years of menarche, very commonly you have got anovulatory cycles. Having irregular periods, especially prolonged periods, is quite common. And in the first year of menarche, we generally say if somebody has periods within every 90 days, we still don't label them as oligomenoric. So she does have periods that are longer, but period cycles that are longer. Her hirsutism is also very mild. So a hirsutism of FGS score of more than 8 is what we say is when we should work up for hyperandrogenism. And ultrasound again is very difficult in young girls because they do have multicystic ovaries, which is quite a common finding in pubertal girls. And also polycystic ovarian appearance can also be there in pubertal girls because of the hyperandrogenism of puberty. So unless this hyperandrogenism is moderate to severe, so an FG score of more than 8, 8 to 15, or you find other signs of hyperandrogenism, like moderate to severe inflammatory acne, or even other signs. Again, anovulation, as I said, has to be age specific. So as the hypothalamic pituitary axis matures, the cycles becomes shorter. So in the first year of Minaki, if the cycle is within the 90-day span, we still do not call it oligomenoric or anovulatory. Of course, they are anovulatory, but they are not significant in terms of this thing. And if such thing is persistent for more than 1 to 2 years, then we say this anovulation is persisting, not showing any signs of hypermaturity. So whenever you've got unexplained hyperandrogenism and anovulation, here you clearly have an explanation. So in young girls, within the first 2 years of Minaki, mild symptoms of hyperandrogenism and ovulation, I would not recommend to get an ultrasound done because PCO appearance is quite common, and these girls are often labeled lifelong as polycystic ovarian syndrome, where there is this just a physiological hyperandrogenism of puberty. They should be reassessed after gynecological maturity, have to be kept in follow-up, and obviously if there is some weight gain, lifestyle disorders, risk of PCOS, but never label them. So no role of ultrasound in these girls. There's only counseling, lifestyle management, and keeping them at risk and following them up.
Okay, thank you. I would like to hand over to Dr. Vijay sir to teach us delayed puberty in boys.
Dr. Vijay? By the time Dr. Vijay joined in, so delayed puberty in boys is defined as no testicular enlargement by 14 years or stalled development, which can also be significant. Very importantly, we don't consider pubic here because that comes from adrenal, and penile size determined by many other factors from that regards. Most boys with delayed puberty have a physiological self-limited form of puberty. In this case, they will have short stature, they will have no pubarchy, and they will have no features of anosmia. Pathological causes in boys are more likely to be hypogonadotropic.
Sorry, there were some technical glitches. Yes, please.
Okay, so I'll continue with this slide and then you can carry forward from there. Yeah. So hypogonadotropic hypogonadism may be functional, which is mostly nutritional, as Dr. Vijay talked about earlier, or permanent because of MPHD or isolated ones, or pathological in which we have hypergonadotropic hypogonadism. So lack of pubarchy and short stature suggests CDGP or functional cause. If there is low FSH, we are talking about hypogonadotropic. Otherwise, it's a hypergonadotropic hypogonadism. So Dr. Vijay, you can take over from here. Yeah. Dr. Vijay?
Yes, sir. Am I audible?
Yes, you're audible. Yeah.
Yeah. Yes. What are the pointers against constitutional delay? That if there are puberty or say normal growth spurt, stalled puberty, or say neurological features are there, the chances of CDGP is low. Why it is so? That in CDGP all the things are going to be stalled. सब कुछ पीछे चल रहा है, पर अभी इसमें क्या है कि कुछ कुछ चीजें नॉर्मल हैं, then it is not CDGP. So this is really very important because the two things are really very different. One is that you are very sure that the child is going to have normal puberty later on. But here, in case of organic lesion, we have to really be cautious that if there is puberty and the child is having delayed puberty, then something is going to be. This is not simple constitutional delay of growth and puberty. Next slide, please. Yes. So how we are going to approach a case of delayed puberty in boys? boys. So we have to see what is the screening test, that what is the gonadotropin level. But before so the child should having normal hemoglobin, this normal liver function test, renal function test, and say liver function test. These tests to be normal. If we are going to deal with this type of things, then it is time to see the gonadotropin level. Where it is low, we have to do the karyotype. It is, if it is high, we have to see the dihydrotestosterone, that is DHT. And if this is low, it means that is 5-alpha reductase deficiency we are going to deal. If it is high, that the previous case has been discussed, it is probably
So I think there are some technical glitches there. So essentially you have to do screening test followed by gonadotropins. High gonadotropins basically go for Klinefelter syndrome. Low gonadotropins look for pointers of HH. And now we are realizing that if you combine inhibin B and testicular volume, that's a very wonderful test. If testicular volume is less than 1 ml, inhibin B is less than 50, that is permanent HH. Testicular volume more than 3 ml, definitely it's most likely CDGP. 1 to 3 ml and inhibin B is more than 100, you will get CDGP. So very important to look at inhibin B now to differentiate between constitutional delay versus a permanent HH from that regards and that concerns. So we'll now carry forward with the cases.
Coming to the cases, next case, 16-year-old boy came with the pubertal concern. Onset was at 13 years, but it stopped for 2 years. Testicular volume was prepubertal, 3 ml. It was soft and pH was 3. Height was 170 centimeter. And he was diagnosed with constitutional delay in growth and puberty. I would like to ask Dr. Apita ma'am to tell your insight.
Okay, so looking carefully at this boy again. So at 13 years, he had started puberty and then had stopped. So it is a case of stalled puberty. So it can be anything but CDGP. As Sir mentioned, that if the child is having stalled puberty or has a normal growth, which is there in this child, he's a particularly tall boy of 170 centimeters. He has normal pubic hair of P3 stage. And we need to inquire now that if he has any neurological features, because he was entering into puberty, now has stopped. So it may be a case of acquired GnRH deficiency or Klinefelter in case of stalled puberty. So was the imaging and the gonadotropin levels done in this child? So
No.
the MRI shows craniopharyngioma. We can further look at the child and differentiate between Klinefelters as well as the acquired GnRH deficiency, because as we saw that the testis was soft in this child and not shorty, which will be seen in Klinefelters, and there was absence of gynecomastia. So clinically also it appeared to be a case of acquired GnRH deficiency, and which was confirmed on MRI.
Thank you, ma'am. Case 16, 17-year-old boy with the pubertal concern. The puberty onset was at 12 years, now stopped from last 3 years. Testis was prepubertal, 2 ml firm with gynecomastia. Height was 182 centimeter. I would like Dr. Padmapriya ma'am to approach this case.
Yeah, thank you. As Arpita madam discussed about the last case, she was telling about the testicular volume. Here, the child had a tall stature, that is around 182 centimeters, and child had stalled puberty also. But here we have to look into the testis, which is 2 ml, that is small and firm. So shorty firm testis along with the gynecomastia points towards Klinefelter. And here it is essential to do karyotyping in this child, as the child had short firm testis along with gynecomastia, where as expected the LH and FSH is elevated along with reduced testo. Again, it is a case of hypergonadotropic hypogonadism due to primary gonadal dysfunction, and the most likely diagnosis here is Klinefelter. So any child who is having delayed puberty along with short firm testis, always look into karyotyping to rule out Klinefelter.
What is the key message, ma'am, from this case?
So if the child is having high FSH and shorty testis and stalled puberty, think of Klinefelter, do karyotyping. Thank you.
Thank you, ma'am.
Thanks a lot, Dr. Ria, for the wonderful discussion. And I'd like to thank all of you, all the team which was involved in the whole process, the pubertal group, Dr. Vijay Jaiswal, Dr. Yutika, Dr. Aisha, Dr. Arpita, Dr. Padma Priya, and Dr. Ria for covering this topic. All of you can go and have a look at our website, which provides a lot of information about pediatric endocrinology, our app, which have got interpreters now pretty much of every aspect of pediatric endocrinology, and our publications. So I'd like to now thank all of you who have joined for such a long time. It's been now 3.5 hours that we have been continuously streaming, and a lot of people are still there. There are some questions which are there, which I'd like to take up now. What are the normal levels of FSH and estradiol in puberty and pre-puberty? So estradiol levels usually will be undetectable before puberty in girls, and even in puberty also the levels are fallacious because they measure immunoassay, and early stages it may be low actually. FSH levels may be up to 2 or 3. We don't worry about that. So LH is more important, as Dr. Vijay had talked about. Is there any specific timing Dr. Geeta is asking regarding sending LH-FSH in estradiol? So generally, the very important point Dr. Arpita had mentioned that we should take a pooled sample because they are pulsatile hormones. So they should preferably be done in a pooled sample. Combined, take 3 samples and then you just test from that perspective. And the other thing to remember in this scenario is that timing, if you want to really look at the onset of puberty, because GnRH pulses start happening at the night time, we will usually have to have the LH levels in the morning. So that's something which is helpful. But usually now with the immunoassay with higher sensitivity, we are now able to get the diagnosis correct in most cases with a baser sample. If in doubt, go for a GnRH testing, which will give us a much better clue. Dr. Varsha is asking why same gender twin require repeat thyroid functioning. So same gender twin, there is a possibility that we can be dealing with a monochorionic and twin-to-twin transfusion. So this is something, that's why we talk about that. And role of cumulative dose of thyroxine if a child missed thyroxine. So generally we say second day you can do a repeat dose, but not beyond that. This is what we usually follow from that regards. Okay, so we will have the session recording which will be uploaded on YouTube, and it's already there as part of live streaming. We'll also be posting that from that perspective. So at this point of time, it's been really a wonderful session. I like to once again thank Dr. Padma Priya, Dr. Arpita, Dr. Aisha, and Dr. Yuthika and Dr. Vijay, who have been part of this program. And since the afternoon, we have had an extensive session. So all the team, Regency CDR, Dr. Vibha, Dr. Alappan, Dr. Nimisha, Dr. Ria, Prashant ji, Nikhil, and everybody have been taking part of it. So I'll thank all of you, and we will be joining again tomorrow at 2 o'clock. We've got very interesting 4-hour sessions, which are there, including electrolyte, glucose, calcium, and DST. So looking forward to joining all of you at that point of time. Maybe we'll have a quick feedback from Dr. Aisha and the people who are there in the panelist group. Dr. Aisha.
Yeah, sir. It was a very well organized and very useful session. I think all the participants must have gathered knowledge. The questions were very basic and covered almost all the aspects. So it was really very informative.
Thank you. Thank you, Dr. Padma Priya.
Yes, sir. It's a very structured program, sir. Followed by session, followed by question and answer. So it will be very easy for people to understand the concept and then go through the case, what they encounter in day-to-day life. So it is really very, very useful program. Instead of watching all our lectures for quiet hours, it is very easy for them to understand even in a short span of time. Thank you, sir.
Dr. Arpita.
Yes, sir. So this is, as everybody has mentioned, it is a very useful and a very structured module in which you present this conference and CMEs. And rather than didactic lectures, the case-based scenarios which we have and the discussions is quite useful for the practicing pediatricians as well as the residents. So it is quite informative in that sense.
Thanks a lot, everybody, and we will look forward